join us globally. So I know there's a lot of you that have been registered for the past few weeks, and I'm sure the numbers will come and go throughout the day. So thank you for joining as you are and wherever you are in whatever time zone. We appreciate your being here. Next slide. And with that, I want to thank and recognize our course director, Dr. Pistowski, and our faculty, Dr. Singh, Dr. Packer, and Dr. Tung. This course would not be complete or even anywhere without you. Thank you so much for bringing it together and leading this conference. And with that, I'll transfer it on to you, Dr. Pistowski.
Thank you very, very much, Ishita. Let me just press control. Couple quick opening comments before I get into my slides. I want to thank Medtronic, Ishita in particular, and her team for really a lot of help in putting this together. For folks who've never done a virtual program, an international one to boot, you need to know that there's an enormous amount of the backstory. I'll have an easy job today because I have an incredibly expert panel with me who are going to regale you with their intellect and lectures. I have Dr. Douglas Packer from the Mayo Clinic and Dr. Jag Singh from Mass General and Roderick Tung, who is now at the University of Arizona. Some of you may have seen some earlier editions of the program. Dr. Sylvia Priori was to be with us today, but unfortunately, she's had a last minute conflict and she can't join us, which is unfortunate. She always adds luster to the program. But we're going to go through some brief lectures, some questions we can take, and then we have some unknown tracings and some complex, difficult clinical management cases to go over. We want to keep it interactive. Please send in your questions. We'll try to take as many as we can, but time limitations may preclude that. This is a course that we started years ago, the concept to give quick updates in major areas of EP to people who mostly have been out practicing or at universities in the field of electrophysiology. We know that there'll be others on, and hopefully you'll gain a lot from it too. So having said all that, let me go ahead and get started. I'll give the lead-off talk for the symposium, and there's been a lot of interest in me looking at this whole issue about ICDs and primary prevention for non-ischemic cardiomyopathy, and I thought it would be a good idea to run through the latest data and at least tell you where my thoughts are and see what the panel thinks also. This is actually taken from a recent debate I had to do on this at Heart Rhythm Society program last year. We have to really start, and Rob, let me ask you, can you see or do I have to access a pointer somewhere?
No, we can see it. Thanks.
Okay, thank you. All right.
You've got it.
Thank you. So this is just from the guidelines years ago, just showing you all the different studies. And I don't want to go through all of them, but I do want to point out two, because they really are the bedrock studies, and particularly SCUD-HEFT, that allowed non-ischemic cardiomyopathies to get approval for a primary prevention ICD. The entry point for SCUD-HEFT, which I'll go into, is less than 35% or less EF with heart failure symptoms. Definitive didn't quite make their goal, but they were close. So the main reason was because of the SCUD-HEFT study. And let me just review for you the bottom line from SCUD-HEFT. Now remember, they didn't subdivide it into ischemic and non-ischemic. They were counted together. And you can see if you look at the mortality rates over time in patients who received an ICD, it's shown in this kind of purple color, they were statistically lower than individuals who received amio or nothing at all. And for those who are a little younger in the field, may not understand why amio was part of this. For many years in the early days, even prior to the ICD being a therapy we had, amio was typically used as a drug to prevent sudden death. It is not in the armamentarium anymore because multiple trials have shown by itself it does not do a very good job doing that. Now, this is a subgroup analysis, and as everyone knows, subgroup analyses are food for thought, but they're not the bottom line. But it's concerned a lot of individuals because when you broke it down, the ischemic etiology, ICDs were strongly positive for preventing sudden death. And the non-ischemic, it didn't quite meet the famous, 0.05, but it was close. And so there are some who always, less than 0.05 rather, there were some who always question, well, maybe it's a little weaker link, but again, it's a subgroup analysis, right? And there is another part of the SCUD-HEF that's often forgotten that I'd like to remind everyone, and that is amiodarone is not always a benign drug. In class 3 patients, amiodarone actually caused increased mortality. And those of us who've used it for 40 years can tell you there's always been a bit of a worry about amio. It's not a benign drug. And this, just keep that piece in mind. It's not part of my talk today, but I think you should remember that. Also, there was no placebo comparator that's in this. It was really just amio, ICD, or best medical therapy at the time, which is not the latest drugs. Then comes Danish that turned this whole concept on its head. But I think you have to take a close look at Danish, and I'm going to go into it in detail because is Danish the same as what you and I see every day in our offices? Let's pick it apart a little bit. There's nothing wrong with Danish, but I think you have to understand who was in Danish, what therapies they got, and how that interacts with the previous data. There were a little over 1,100 patients enrolled. Their EF had to be 35% or under, so very standard group, New York Heart Class 2 or 3, and they were randomized to ICD or usual clinical care, and that was just whatever usual clinical care was. This is a very important observation here because I went back and looked at our data. We have a fairly robust patient volume and ICDs in our own practice of our 16 EPs. And I went back and took a look. And if you just looked at every non-ischemic in our practice, you're not going to find the mean QRS duration of 146. It was really more in the 120 to 30 range when I looked at it. And because of all this, this is really important. And I suspect that when we hear from Dr. Singh later, he'll go over this in more detail. The advantages of CRT, which are very big in helping people and preventing sudden death. So 58% CRT ICD and 58% in the control group. So nearly 60% of all patients got a CRT device. And the bottom line of the Danish study, if you can see here, there was no difference in overall death from any cause. There was no difference in cardiovascular. And I know it's hard to see some of these, but there was a sudden death advantage, but you can see it's kind of small. Okay. Once that was published, you can imagine how many meta-analyses came floating out. And it was amazing how fast they came out. I mean, this is just one of them. There were several. And so, you know what these meta-analyses do? They throw everything in a Waring blender, and then you get what comes out. So I'm always a little wary of meta-analyses. If it suits my side of the argument, I'm going to be prone to show it to you. I may not show it if it's the other side. And that's what people do, because it's not prospective randomized trials. It's just taking a whole bunch of trials and putting them together. Anyway, most of the meta-analyses that came out said even with the data presented from Danish, there still was a survival benefit favoring ICD. So this set up this, okay, Danish says this, the meta-analyses say that, SCUD-HEF, there was always that question. And a lot of people just said, I don't know what I'm going to do with this group. And I can understand that. I was sort of in the same boat. I'm trying to figure out, should I change my way of practice with these folks? I want to bring in some additional data, though. That if you look at, let's just look at ischemic versus non-ischemic as far as their clinical course over time. I think these are valuable data from the whole MADE IT series of studies. And there was a whole bunch of them. Didn't matter if you were ischemic or non-ischemic, your VT or VF over time was about the same. And I have to say that's a little surprising to me. My experience has been a little more ischemic, but these are prospective data. But people with ischemic heart disease have other reasons to not live as long. And indeed, in the all-cause mortality, ischemic didn't do as well. So you can imagine, the defibrillator it does one thing, right? It takes a life-threatening rhythm and brings you back to life, but it doesn't change your anything else. I mean, it gives you a chance to keep living. And if you have some other factors involved, such as all those things that occur with ischemic heart disease, you're still not going to have as robust a lifestyle. And then you go back to the CRT, and I'm going to go back through some very old studies. This is almost 20 years ago. This was one of the ones that was done at the time by Guidant, and no longer Guidant got sold, but looking at CRT versus, at the time, optical medical therapy. And that's nothing like modern optical medical therapy that we use today. But at the time, that was the comparison. So, and if you look at CRT versus OPT and CRT-D versus OPT, and you look at the red line, which is optimal therapy, death or hospitalization for both of the CRTs, they had a better outcome. So we've already learned for 20 years ago, right, that CRT improves your chance to survive as well as to decrease hospitalizations. This is a secondary endpoint. I'm not making a big deal about it. I mean, they made a big deal of the company, obviously, because they found, if you looked at a secondary endpoint of all-cause mortality, that optimal medical therapy did not do as well as a defibrillator. Okay, CRT was I mean, if you looked at this eyeball, you'd have said all CRT as well as CRT-D did about the same. I mean, that's when I remembered seeing this, but statistically, only the D won. But boy, the lines are close. So again, CRT by itself helps. Remember, 60% of Danish had CRT. And then I think a very important study came out from the investigators in England, and they looked at the CARE-HF. And this is just looking at CRT, no D added. And you can see that it's looking at a composite endpoint, which isn't just death, it's, again, the hospitalization. But again, at the time, optimal medical therapy did not do as well as cardiac resynchronization. Additionally, this is actually from our group, and again, the previous study stressing no defibrillator component, just the pacing component, CRT-P. This is from Joe Manfredi, a fellow with us, put this nice study together. I was just interested in asking a simple question, and which Joe, I think, solved for our group at least. We took a large group of people who had CRT put in for primary prevention, and we just looked over time at how their chance of an arrhythmia correlated with their heart function getting better. Now, there was always literature saying if you remodel the ventricle, you seem to do better, less arrhythmias. But actually, we looked at specific EF parameters, and you can see as your ejection fraction gets better and better, your chance for any life-threatening arrhythmia is in the 1 or 2% range. Again, if you're giving somebody CRT therapy, I mean, you've already booked in the fact they're not going to have a very small chance if they respond really well to having a sudden death episode. All right, so let's come full circle here and look at the most latest data. This is just published this year from the Danish investigators. And now we find out that they looked at everything and they found what's the long-term follow-up of Danish all-cause mortality. And again, I'm sorry, this is a little hard to see, but if you look closely, you can see that the only group that derived benefit was the group that was less than or equal to 70 years old. And there they make a statement, they clearly derived benefit. So I went to their study group and asked a simple question: what percentage of their group was less than 70 years old? And guess what? 74%. So I think if you want to argue over 26% of the other patients, go argue over it. But even the Danish investigators have come out in the latest paper and said, if you're under 70, then you derive benefit. You decrease in all-cause mortality. I think that's important to remember. That's the problem when you mix too many things together. So does that mean now, Dr. Prstowski, I am giving everyone an ICD who has a non-ischemic myopathy? Not necessarily, because even though the guidelines will clearly tell you, I mean, these are the updated guidelines from several years ago, that if you have class 2 or 3 failure, heart failure, and EF 35 or under, and you have no other reason not to get an ICD for something else going on, it's a class 1 indication. Okay, so it is keeping with class 1 medicine. But for all of us, when we deal with primary prevention of anything, it's a risk-benefit analysis, isn't it? We give anticoagulants and we talk about what's your bleeding risk, what's your stroke risk, And I think it comes down for all of us to, in our heads, thinking, well, there's 3 groups we deal with. We deal with people in a general risk group who are high risk. We also have in that same grouping some very low risk patients. And then there's some in there that are minimal risk, really low risk. And depending on where your funnel's at, some people have a very low risk tolerance, and all 3 balls will come through. There's some people who are really tight, and only the highest risk in that group comes through. I like to think of myself maybe a little bit more this middle guy, but we all have our own opinions of how to risk stratify. What I incorporated now routinely in what I do is fibrosis. I think that I'm only going to show you a couple studies, but I can tell you there are many studies that support this concept. So in patients who have non-ischemic myopathy, as you all I'm sure know, there's a large group that have this positive gadolinium enhancement, and they have SCAR. And if you look at the folks with SCAR from early studies, and there's many that have shown this is true, if you look at sudden death or even mortality, patients without fibrosis, it's not 0, but it's very low sudden death risk. And let me just show you a couple others. Here's a more recent study in 2022, and they looked at visual versus, trying to polarimetry how much SCAR, but just visual, which is really the way it's always been done. Now, I wouldn't tell you 0%. I think that's how their study worked out. But look at this. These are non-ischemic cardiomyopathies with no evidence of any myocardial fibrosis on CMR. And during their follow-up, 0 sudden death. It doesn't mean that's not going to be true for a large series. But the point is, it's a very good added risk stratifier, in my opinion. And actually, there are data, this is only one of several studies that show you're better off having an EF of 25 or 30% and no SCAR than to have an EF of 45% in SCAR. You're actually going to have a higher sudden death risk, and all EPs should understand that. SCAR allows people to have serious arrhythmic circuits, so none of that is a surprise. So I'll get to you in a second. I just want to finish up. So I'm going to show this, and then I'm going to let the faculty opine for a second. This is kind of where my head's at now, but I'm telling you, it's my opinion. I'm not going to tell you that anyone should ever do anything that based on this. But this is where I'm sort of at right now in my shared decision making with patients. If I have a patient who has no SCAR and their EF is over 35, obviously they don't meet criteria for forget the CRT part. I'm going to let Jag talk about that. But just pure for a preventive ICD. If they have an EF that's under 35% and they meet CRT, and again, I'm going to let Jag opine on his own. I'm sort of going more to a P versus CRTD. That's me. That's not mean you have to do it. And if they have no SCAR, part of my discussion with the patients now, it's a part of the discussion, doesn't mean I always come down to this, is to let them know they are in a very low risk group for sudden death. And that's part of my discussion with them. On the other hand, if they have SCAR, they definitely are going to get an ICD, depending if they meet criteria for CRT, it'll either be a D or just a routine one. And there are no data, I'm going to say this twice, there are no data to substantiate what I'm showing you here. Other than, there are data to show if you have SCAR and you have a 40% EF, you're greater risk of sudden death, but there are no prospective data saying giving that person an ICD changes their course. But this is just where I think research should go in the future. I'm going to stop my talk. And Doug, Dr. Packer, did you have a comment you want to make before we look at questions?
Yeah, just one of the questions that I've got is I wanted to know your opinion on how you treat SCAR and gadolinium findings. Do you do it in a binary fashion? One of the big arguments that's been ongoing for maybe the last 10 years is it 15% scar? Is it 40% scar? Or is it any scar? Do you have a recommendation for us of when do we invoke, how much scar do we have to invoke that as a bona fide risk factor?
Thanks for bringing that up. That's a great question. It depends on the pathophysiology. So for non-ischemic dilated cardiomyopathy, the one I was talking about, there have been several studies showing the presence, not how much, gives you a risk factor. It's sort of surprising to me. I would have thought the more scar, the more risk you are. But it hasn't worked out that way in at least 3 papers I've read on that. However, in the hypertrophic cardiomyopathy group, you're spot on. There have been several papers that have shown scar burdens of like 5% are not a major risk factor for sudden death, whereas 15 to 20% are. So appreciate you bringing up that point. But in the non-ischemic group, it appears that if you have scar, presence of scar, even if it's 1%, you're at risk for sudden death, Doug. So, Jag, your question. Oh wait, you have to turn your Jag. You have to turn your mic on.
Always make that mistake still. So more of a comment, and I love your algorithm out here, but I'm going to poke a couple of holes in there because there are many nuances to the delivery of device therapy, which I think we need to be cognizant of as we approach these patients. I think scar is really important. For sure, I think there is a linear relationship with scar burden and outcome, and even the presence of scar itself is a huge determinant of how patients do. But there are many cardiomyopathies that are smaller. We may call them zebras. For example, Lamin cardiomyopathy, that is a genetic myopathic process that is associated with high incidence of sudden death that don't have scar. And I think we need to kind of keep those in our minds, that we need to be looking and ruling out every other cause why a patient may not require an ICD before we go down and have an algorithm specifically. The second thing I will say is, we only know what we know, the common Rumsfeld kind of saying. And if you look at, machine learning strategies now for risk stratification of patients requiring ICDs or no ICDs, and there's a really elegant study called the Swedish HF registry study, which looked at over 50,000 patients and did machine learning and found that there was actually a significant overlap between EF of 35% greater and lower in the risk for sudden death still. And that's because there are many other contributing covariates that we don't understand. And I don't think we have an answer to that right now, but I think in the future, as we develop better risk stratification strategies, we need to be taking into consideration multiple other covariates that we don't understand the interaction with, but will only be able to be answered with more sophisticated predictive analytics and machine learning.
Yeah. Jag, thank you very much for bringing up all those important points. One of the problems of putting up an algorithm is that even though you say 3 times, this is my personal algorithm, is that it does open you up to bullets coming from all quarters. And all of your comments are perfectly legit. I was focusing this on a thought process when you see a patient, and you are spot on about making sure you've got the right diagnosis. This does not pertain to laminin. This doesn't pertain to, ARVC. I mean, any of that. I'm talking about the patient that you and I and Doug and we all see, that you've gone through all your stuff, you've done your genetic testing if need be, and this is just a non-ischemic dilated myopathy with no other clear etiology. And it's my approach, and I'm telling you, I'm not married to it. Several questions have come and asked me about that. This is a point of discussion in the office. We use this shared decision-making concept now. I've been doing that for over 4 decades. I used to just call it being a good doctor, but we now have a name for it. It's like the Wizard of Oz. At the end of the Wizard of Oz, you give him a crown, he's got courage. He's now got courage. Well, look, we all try to be right. We all try to be good doctors in the office and talk risks and benefits with patients. And that group on the left here, and several people have sent in questions. I'm not saying that I never do anything. I'm not saying that at all. I'm just saying that I have that discussion with patients. I tell them in the bucket of risk that you're at the lowest part of that bucket. If you still feel like you want a defibrillator, we'll give it to you. It's class 1 guidelines. If you feel, knowing that you may not want one, that's part of the discussion, right? But you're right, Jag. This assumes you've done your complete workup and you've ruled out other things. One question that came in, I don't want to go too long because I'm going to cut into your times, but another question came in about electrophysiology testing. Now, apparently they said, I haven't read the ESC guidelines, so I'm sorry, I don't know what they said. All I know is back in the 80s when we were studying all these things, we wrote a paper on EP testing in non-ischemics, and we found it to be not very reliable. A lot of them are not inducible. I'm welcome to see new data to say you want to do it. But we went through all this. For those who are younger in the field, the MUST study that I know Doug was involved in with me, we showed that serial EP testing didn't really work out the way we thought. So I'm welcome to new data, but I can tell you from a lot of data in the past, I have not found electrophysiology testing a good stratifier. So for me, at least.
Eric,
Yeah.
this is one place, the ESC guidelines, I think are very, very good. But I also think that this is one place where they got out in front of themselves.
Well, I'm glad to hear that. Oh, got over their skis, as they say.
As it were.
As a word.
Eric, can I add another comment? Just
Yeah, certainly. Yes.
Yeah. So I think a subset of patients don't respond to CRT also, right? And those could be even left bundles, but majority of them obviously are non-left bundles. And I think while having that shared discussion moment, having that conversation that there is a small chance that resynchronization therapy may not actually improve your ejection fraction, and the likelihood of then at that point in time revisiting and adding a defibrillator lead may be something we'll need to consider.
That's great. I'm going to pass the baton in a second, but one last question. I'm curious to get both Jag and Doug's opinion. One of the questioners says, I don't agree with this, but obviously it's coming from his or her own experience. Almost all cardiomyopathies must have lots of scars. Actually, that's not been my experience. A whole bunch of people that I've put through MRI studies have no visible scars. I mean, they may have with fancy whatever, processing something. Doug or Jag, what have been your experiences with that?
Well, I would agree with that. I mean, all non-ischemic cardiomyopathies are not created equally. So if we're going to go for a little bit of sarcoid or a little bit of cocaine or, some other things, you may have very little. And even in the patients that have a fair amount of, or a fairly low ejection fraction, it doesn't mean that they're going to have a lot of scar. They might. And it comes back, Eric, to the reason why I ask about, percentages. This is the place where even in the non-ischemics, the percentage issue comes up. And that's, even there, I think some people, including me, feel a lot better if I'm seeing 10% scar, percentage.
Well,
even when it's not
Doug,
hypertrophic cardiomyopathy.
Yeah, no, Doug, I mean, that's what you would think, right? I mean, and I agree. I mean, there's just something intrinsically reasonable about that. But when I reviewed the literature on this, paper after paper, there've been several have shown, they've looked at, is it 0.1%? I mean, 1% versus 5%. Maybe if you had a really, really large study, you'll see that it's going to come out that there's definitely an increased risk. And it makes sense, doesn't it? But to date, the key is even the presence of some scar puts you at risk. And I don't disagree with your comments. It makes sense. It just hasn't been shown yet. But I think maybe they need larger studies.
Yeah, I would suggest that most of the studies that really kind of put out using very low scar percentages are meta-analyses. And if you look at the 95th percent confidence interval, even though the median may be in the direction of device implantation, the 95th percent confidence intervals over the null line. So I agree with you. We still need some more studies here to decide whether there should be anything binary or not.
If I may just add to that, I think the presence of scar is something akin to atrial fibrillation, Doug, where, you know, the longer you're in persistent AFib, the more fibrosis you develop, right? Because of the remodeling. And I think akin to that, the longer you've had the myopathic process, if you catch the myopathic process early on and you're able to reverse it, you may not have scar. But if you allow the myopathic process to progress and you take an MRI at day 30 and you take an MRI at day 5 years, you probably will have scar at 5 years if the myopathic process has continued to progress and have dilatation and associated fibrosis out there. So I think that's something to kind of put into perspective as to where you actually catch the myopathic process.
So there's tons of questions, and I feel terrible cutting this off, but Jag, that was a great segue to Dr. Packer, because we're going to have him talk, and I know I've seen a preview of his slides, and I know he's going to address a little bit of this scar stuff, right, Douglas? So
Yep.
I'm going to turn to Dr. Packer, who needs no introduction to anyone, is going to talk. I asked him to talk about AFib, and obviously, I mean, he can talk about other things, but he's done so much work in this space. And I've asked him to kind of hone in on just some key points because obviously, even from Cabana alone, he could talk forever. So, Doug, why don't you fill us in on your latest thoughts on AFib?
Yeah, thank you, Eric. I think the one thing that we saw in Cabana that was a little bit surprising is what we saw in patients that had HFpEF. The patients who had HFpEF did very, very well with the DANF ablation. Patients who didn't have HFpEF, if they had HFrEF, then it was different. So I just thought that it might be interesting to go beyond Cabana. Most of this is going to be beyond Cabana, and just give everybody a chance to think about this. So I have some potential conflicts. The top are advisory boards, the middle is funding, and the bottom is intellectual property. And there's one down off the screen that you see that there's my name in a black box warning. There's a lot of these that, recommendations and findings that have not stood the test of a rigorous randomized clinical trial, and that's getting to the point, Eric, where we're looking at Cabana HF. So the problem, it's like your kids, Eric, when they were 14 or 15. Then a lot of us have good kids, and a lot of us have kids that you put two of them together and there can be a little bit of a problem. And this is just the case of heart failure and atrial fibrillation, is that when those two travel together, there are considerations that have to be made. When we were talking back years ago about tachycardia-induced cardiomyopathies, we'd use this and say, well, which came first, the chicken or the egg? If it's the chicken first, then you'll get an egg. If the egg hatched first, then you'll get the chicken. And the question is, if it's a tachycardia-induced cardiomyopathy, then it may be your atrial fibrillation with a very fast rate that then leads you to heart failure. But when we get into start talking about HFpEF, then we talk about incidence arrhythmias and in a patient that has some kind of risk, and that risk has to do with, on the one hand, you can take a look at it and you can see that you can have atrial fibrillation. This is what Jay was kind of saying. You have atrial fibrillation. As time goes on, you can get progressive fibrosis, and they behave more like HFpEFs. On the other hand, if you have the HFpEF first, then there's a prevalence of atrial fibrillation that can occur, and it can be as high as 50%. So these things can go either way, but when they work together, then there's a problem. Now, this is a slide from Bill Stevenson that looks at class 1, class 2 to 3, 3 to 4, and class 4 functional classes. And You can see with Solve Preserved that this was kind of a HFpEF study. There really was not much in the way of percentage problem of atrial fibrillation. You go all the way over to consensus, and what it looked like, you told us a little bit about that, then about 50% of the patients had atrial fibrillation. Now, in looking through these, since I'm going to be focusing a little bit on HFpEF, if you look at iPreserve and CHARM, and if you look at Paragon and Paradigm, and if you look at Emperor and Emperor Preserved, there's going to be a variability. But if you look at patients who have underlying heart disease, you can have anywhere, now the numbers are closer to between about 15 and 50% are also going to have atrial fibrillation. So it's a situation where we have to pay more attention to it. And these are some of the studies that I just mentioned that are more recent. And if you have Relise, then you're down around 18%. If you have CHARM Preserved, then you're about 25%. iPreserved at 27%, so 27, 28%. But you get into other studies, then that becomes significantly higher. And so that the event rates are higher, and they can be up to 50% if you're looking at heart failure hospitalization, or you can be up to 40 or 50% if you're looking at cardiovascular mortality. So let's look at the interaction between atrial fibrillation and heart failure. I mean, is it chicken? Is it egg? Is it turkey? Is it duck? You kind of have to take a look. So this is from the guidelines from 2014. If we're going to look at atrial fibrillation, then there are a whole bunch of different things that can create problems. One is if they have structural abnormalities like fibrosis or dilatation, ischemia, infiltration, or hypertrophy, then that can contribute to atrial fibrillation. But you have to be careful because it goes in the other way too. Inflammatory oxidative stress. If you look at the renin-angiotensin system, if that gets activated, then that can lead to some of these findings where you get fibrosis and more ischemia. And it was just mentioned a little bit ago that it kind of depends on if it's been 3 years or 4 years or 5 years. There's the factors that are autonomic nervous system, and then just atrial structural abnormalities like heterogeneity, conduction, action potential, automaticity, and so on. And the one thing they didn't mention here is the patients who have left atria that are abnormal, and they have non-compliant left atrial factors. And then there are genetic variants, channelopathies, myopathies, atrial tachycardia remodeling, and then all of the things that Prash Saunders talks about, hypertension, obesity, sleep apnea, hyperthyroidism, and drug. All of these lead into atrial fibrillation. But now there's a point we have to make, and we have to make it fairly quickly, and that is it can go the other way too. You have atrial enlargement, existing atrial disease, fibrosis, ischemia, hypertrophy, hypertrophic changes, mitral insufficiency, and increased LA pressure load, left atrial noncompliance, or HFpEF. Then that can progressively lead to more heart failure over time. And that can get up into the 30 to 40% range. In Cabana, we had 2,200 patients total, and 770 had heart failure. So then I think a point to make here, Eric, is that I don't think that we can just look at atrial fibrillation by itself. I think we have to look at the comorbidities. In this case, it's heart failure. And as you put the heart failure comorbidities in there, then the two walking together can have more problems. And in fact, they get together, and there can actually be newer mechanisms of how that gets into trouble and what it eventually means. Now, one of the studies we're doing is we're looking at inflammasomes or fibrosomes. And this is a study that's nice because it shows you the signaling 1, signaling 2, and these are surface receptors. But to take this all the way down through, you have a number of different bodies in the cytosol, but you also have a set that has to do with fibrosis. And if you take a compound like NLRP3, NLRP3 is a bad one. And what happens with NLRP3 is you get the fibrosomes, and then it is progressively more problematic. You can get caspase, particularly caspase 8, 9, and there are a number of cytokines that work to the promotion of fibrosis. If you look at interleukin 1 and 18 in particular, and then if you look at caspase, then you can get into a situation where you can have fairly substantial fibrosis. And so the reason why I'm talking about this stuff, Eric, is, there've been decaf problems, or decaf2 problems that I'm going to look at in a minute here, where in one case, fibrosis was really important. And if you did something to take care of it, ablation worked better. Decaf2 didn't work that way. But it's the same thing. And the thing that we're learning over time is this whole business of fibrosis or fibrosomes that leads on to create collagen 1 and collagen 3 and titin and elastase, then you can create some fairly significant problems that create fairly significant atrial fibrillation. Now, this is studied by Khalife, and here he's looking at the percentage of fibrosis, and he's eventually going to get to galactin-3 inhibitors, because not only are there different compounds that create the fibrosis, there are compounds that block the fibrosis. And here, if you look at just using saline, you can get a pretty good degree of fibrosis. If you're looking at a galactin-mediated compound that blocks, then you're not going to have the same degree of fibrosis with the blockers. And that's important because look at persistent atrial fibrillation. In control or not, if you use TGF beta, and this is what we used in the Jared Bunch paper, then there was a lot more atrial fibrillation than if you didn't have TGF beta. Same thing is if you were just using a control, and so you didn't have a drug or a compound that was creating the problem, you had a lot more persistent atrial fibrillation. So what we're looking at is, how do you get this fibrosis? We can talk about obstructive sleep apnea. We can talk about hypertension. We can talk about diabetes. We can talk about obesity or an elevation of BMI. You can look at those, but how do they do what they do? And the answer is, this is how they do what they do. And you can get them all in there. And if you don't have some way to block them, then you're not going to get a benefit like in decaf2. So we kind of have to talk about risk factor management. There's weight management and exercise, and this is all the stuff that you do there. There's hyperlipidemia, and this is all the stuff you have to do there. Obstructive sleep apnea, and here are all the things that you can do to prevent atrial fibrillation or the fibrosis, hypertension, and diabetes. And so I'm just making these points, Eric, because as we now go on and talk about the HFrEF and HFpEF patients, it all centers around this, and probably to a great degree, fibrosomes and fibrosis, whether you're looking at Hetzeger's papers or whether you're looking at those coming out of Switzerland or anywhere else. So let's talk about treating heart failure and atrial fibrillation. Well, if you look, they both kind of swirl together. You want to get euvolemia to deal with heart failure. You want to ameliorate some of the RAS disturbances. You want to manage the non-cardiovascular comorbidities and deal with heart rate control, and so on up, maybe to reach transplants. On the other hand, you want to prevent and manage bleeding. You want to prevent and treat heart failure, restore sinus rhythm. There are a number of studies. There's a paper coming out from Cabana and a paper coming out from East AFNAT4 that talk about the importance of sinus rhythm way above what was said in AFFIRM. And by far, we need to be able to prevent stroke and embolic events. So let's look at these. Now, where did this come from? These are KM plots that came from TopCat. And here you're looking at the estimate cumulative proposal of patients who died from a cardiovascular cause. And the question is whether it was in certain countries in Europe or North America. In North America, there probably is a real difference in the hazard ratios and the cumulative proportion of patients that will be hospitalized for heart failure. So if you've got a composite endpoint, let's say heart failure, hospitalization, and cardiovascular risk, TopCat as a whole showed that cardiovascular mortality, not much difference. If you look at just the heart failure hospitalization, then there's quite a difference. And if you look just in North America, then the cardiovascular risk differences were very, very different. So reasons to be thinking about heart failure here. Now, here we're looking at paradigm. And I won't go through this to any great extent, except that there's a primary endpoint, which is a composite. There's deaths from cardiovascular causes and heart failure hospitalization or death from any cause. And if you look at these are HFrEF patients. So these are patients that have ejection fractions that are down in 35% and lower range, let's say below 40. And if you look at those, then in paradigm, there actually is a difference, and the hazard ratios are acceptable for suggesting that there is a real benefit and that you are going to reduce overall risk. Well, now Paragon's different. Paragon was a companion trial, and they looked at cardiovascular mortality and heart failure hospitalization. They looked at heart failure hospitalization, and they looked at cardiovascular mortality. And in Paragon, where the patients had ejection fractions above 50%, and then there's some HFrEF patients that are in there between 40 and 50. But if you compare valsartan versus sacubitril/valsartan, then if you look at the overall findings, there's not a whole lot of difference between the groups. So in Paradigm, HFrEF, there's a big difference in treatment. In Paragon, not so much so. Now, if we take a look at Emperor, and this is Emperor reduced, Emperor itself, and the slide didn't drop, but Emperor itself showed that there's quite a bit of difference in cardiovascular mortality and heart failure hospitalization. But now if we look at Emperor reduced, well, this is Emperor reduced HFrEF, there's a difference here. But then when we go to the next slide, we're going to be taking a look at the Emperor preserved. And if you look at Emperor preserved, then you can see how many patients there are with what kind of events they have compared to placebo versus empagliflozin. And here there was a difference, but it's in hospitalization for heart failure, not in total mortality. And so the previous was Emperor HFrEF, and this is HFpEF. Okay, so let's look at treating atrial fibrillation and HFrEF and HFpEF. Now we get back into more familiar country. And this is the plot in the North American portion of the TopCat AF study. And the thing you see is if they had atrial fibrillation at the time of enrollment, then their event rates were higher. And whether you're looking at a higher number of risk or lower number of risk. On the other hand, if they had no atrial fibrillation, and they might have had a history of atrial fibrillation that developed someplace over time, then there's a fairly significant difference between those who had atrial fibrillation at the time of enrollment. So some of this, going back to something Jay said, is depends on if you had it when you started versus when you didn't. So now let's look at studies like CAMERA, the MR study. Now we're looking into the group of patients here. The ejection fraction is less than 33%. You see the consort diagram. And what they're really doing is they're looking at changes in left atrial size and stroke volume. So if you had ablation, then the LA volume dropped by 11%. If you look at the LA stroke volume was better. If you had medical control, you didn't get the same kind of benefit in either side. So this was used to say that if you look in CAMERA MRI, then there's a difference. Now, if we go to the ATTACK study, and this is from Luigi DiBiase and Andrea Natali, again, here is the consort diagram. There are 203 patients, and 102 got catheter ablation, and 101 got amiodarone. There's a trial period, and at the end of the trial, then they looked at overall outcomes. And the patients in group 1 with catheter ablation did much, much better. They had, in terms of freedom from atrial fibrillation, is about 85%. You look down here, there's a lot more patients that had atrial fibrillation just with amiodarone. It simply didn't work to the same degree that catheter ablation worked. And so this is another study that would have favored the notion that if you can do ablation and HFrEFs, you're going to be much, much better off. There are some statistical issues here, but for the most part, this is a fairly good study. It's just that there were so many patients in the control group that had high-dose amiodarone. So let's go to CASTLE-AF. So here's 179 patients that got ablated, and 184 that had conventional therapy. And you can see how they looked at these patients over time, and they followed them over the course of 60 months. If you look at the composite endpoint, which was mortality and heart failure hospitalization, and they also looked at recurrent atrial fibrillation. They looked at a number of different approaches, but here's ablation, here's conventional therapy, and there's a risk reduction of 38% or a hazard ratio of 0.62. And here we don't have the problem with the 95th% confidence interval going way over the side of null. So this looks very, very good. If you look at all-cause mortality, then not as much of a difference, and it didn't show up until 36 months. But when it did, and they were ablated, then the hazard ratio was 0.53, and the risk reduction relatively was 47%. Now, there are issues here, and they have to do with some of the analyses were done as treated, and there are a couple of places where people were looking, and there are some fairly significant differences in the underlying patient populations. But you know, we like to study anyway because we're electricians.
Dr.
So
P,
let's
just
just
a
talk.
quick 5-minute heads up.
Okay,
Thank you.
so let's just talk now about the heart failure portion of the Cabana trial. This is the consort diagram, and there were 1,422 that had no heart failure, and there were 778 that did have heart failure. Most of these happened to have been HFpEFs, not HFrEFs. And when we looked at that, then if you looked at the event rates were significantly higher if they had drug therapy than if they underwent ablation. If you look at those with intention to treat now, again, the same sort of thing in terms of risk of all-cause mortality for an impact of heart failure. There's a large difference, much reduced event rates, and a reduction in the atrial fibrillation rates, which I'll show you here. So atrial fibrillation, the recurrence of atrial fibrillation was less than what it was in those patients who had ongoing heart failure, and this is with intention to treat. Now, I just have a few more slides here. This is from East, and I just wanted to make the point that they saw a difference in early rhythm control, and that kind of means before 1 year, or The median was 38 days. And if you look over here, the ones that were in sinus rhythm did significantly better than the ones that were not in sinus rhythm. Now, mind you, these are rhythm control patients versus standard therapy for atrial fibrillation. Most of these are drug therapy, and there's only about 19% that eventually got ablation. So this is not an ablation comparator. If you look at the occurrence, where there's a reduced ejection fraction, then there's an even greater split here, with the rest being, if it's a primary endpoint or the recurrence of mid-range ejection fraction, not much of a change. So this is from Relig's heart failure paper. So what do we know today? Well, we need to control AF in heart failure, but we also need to control the heart failure. We need to improve the AF burden in heart failure. We need to improve the quality of life in heart failure. We need to decrease the incidence of VT and VPCs. It improves LVEF if treated with ablation, decreases in heart failure hospitalization, and improvements of mortality. So the Cabana HF trial that we're going to be starting is in HFpEFers, and all of them have a prior history of heart failure hospitalization and atrial fibrillation. 1,500 patients from 100 centers around the world, and we'll look and see what ablation does. Everybody has heart failure, everybody has atrial fibrillation, everybody's treated with an ARNI or an SGLT2 inhibitor, and we'll see over the course of 6 years how they turn out. Well, I think that we really can take a look at freedom from atrial fibrillation in some of the cryo catheter studies. This is from Kunis and his group, and there's a difference of 82% freedom from versus 67% freedom from. And there's a couple of other trials that show the same thing. So winding this up, Eric, I think the thing that we can say is that, you know, Cabana and what we think is going to happen with Cabana HF is it confirms prior observations about other randomized clinical trials. Ablation is acceptably safe. It reduces mortality and cardiovascular hospitalization. But it's going to have an effect on early atrial fibrillation, particularly paroxysmal and persistent. That's in for you, Eric. It can be highly effective for first-line therapy. It's null in the primary endpoint, but ablation does reduce mortality in heart failure and in minorities. And it depends on if you're looking at treatment received or per protocol. So, Eric, this is my thought about, we really at this point have to get into the heart failure component of atrial fibrillation and how they interact with each other before we go any further. And if we do that, we're going to find out that I think we're going to be able to move up the heart failure from a 2B to a 2A. And then in terms of very, very early and in terms of first-line therapy, I think they'll move up now into 1A or B. So I'll close there.
That's a fantastic review of things, Doug. We're running a little late, so I don't know that we have a bunch of questions now. What I'd like to do is take a chairman's prerogative to come back to these issues later when we have unknowns and case reports. So, you know, some of these things I think deserve a little discussion. I'll just say for me, Doug, the incredible work you've done and also the stuff from Nasir Marouche. On a personal level, I have definitely been more aggressive getting these people into the ablation lab. So thank you for all your efforts. But just to stay a little bit on time, I'm going to give Dr. Singh 25 minutes, just so you know. I know we've been going a little bit over, but we're not much over. And he's got a very important topic, and there are very few people who have his expertise in this area. And I need to know more about this, Jack. So go for it.
Great. Thank you, Eric. Really want to thank you, the organizers and Medtronic, for the invitation. It's a pleasure and a privilege to be here and be a part of this esteemed faculty. So thank you. So before I proceed, these are my conflicts. I do consult for and do research with many of the major device companies. with that behind me, I know we have a mixed audience, going to focus on EPs, but I'm going to build it ground up because we're going to talk about issues that are evolving in this therapy. So bear with me, the ones who are already familiar with the basics. So I think we all know resynchronization therapy is an electrical fix for a complex problem, right? We have an abnormal activation sequence that results in an abnormal contractile pattern. If you break up the electrical dyssynchrony within the heart that we're trying to correct with just 3 leads or with 2 leads, and we'll talk about that, there's a fair amount of complexity out there. I mean, this could be interatrial dyssynchrony, could be atrioventricular dyssynchrony, could be interventricular dyssynchrony, could be intraventricular dyssynchrony. And even in patients who have SCAR, as we were talking about, there can be a correction that is needed for intramural dyssynchrony. And this little cartoon on the side shows you a rotational venogram that we often do at our place to kind of get a good 3-dimensional perspective of the venous anatomy. And then we put a LV lead in, and I'm showing you a unipolar lead out here primarily because it sounds overtly simplistic that you put a little point pacing on the epicardial end of things and hope that it's going to correct all these levels of dyssynchrony in a failing heart. And most of the times it does, but there are many other things that we need to do along with it to ensure that we're getting the best out of the delivery of therapy in these patients. And the only reason I bring this slide up is for 2 reasons. One is there's a huge emphasis right now on integrated care in patients with heart failure, and especially those with implanted devices. Even though at our center, we had a multidisciplinary clinic for patients getting implanted devices, since 2006, we were able to show the improvement in outcomes in patients who had CRT, had individualized optimized therapy and individualized management of their heart failure along with their devices. Traction for it across the universe or across the country has been limited because of the challenges of trying to bring heart failure physicians, electrophysiologists, imaging physicians, and general cardiologists all together and try to create this one-stop shop. But clearly, I think the value-based care in the management of resynchronization therapy is going to force us to start looking at this in greater depth and greater detail. I'm going to revisit the past, and I'm going to revisit the past because I'm going to raise some questions related to this during this talk, because not all questions are answered by randomized controlled clinical trials, and I hope I have the opportunity later on to, really amplify on that. But I think we all know from the ECHO CRT study that resynchronization therapy in patients with a narrow QRS doesn't really work well. In fact, you can see that there was a heightened mortality in patients in the ECHO CRT patients. So narrow QRS here was a QRS of less than 130 milliseconds with some evidence of mechanical dyssynchrony. And resynchronization therapy actually translated into these patients not doing well and actually having a higher death rate out here. And that changed the whole landscape of how we approach patients with the QRS width. There were many meta-analyses that forced us to go in one direction. But it also heightened the question about, are there different myopathic substrates that do respond and don't respond to resynchronization therapy? And I bring this one up in particular. This was recently published in JAMA. It's chemotherapy-induced cardiomyopathy with a wide QRS. So the notion was that these patients have a myopathic substrate. They've had cancer, they've survived cancer. Probably they're not going to survive heart failure, but if they have a wide QRS, lo and behold, these patients actually do pretty well with resynchronization therapy. And you can see this cohort of patients. This was a multi-center study in about 14 different centers with cardio-oncology patients. And we were able to show that uniformly resynchronization therapy in patients with a wide QRS, and I'm going to amplify the word wide QRS because I'm going to revisit that right at the end of this conversation, actually translated into much better outcomes in these patients. Having put that behind us, I think there is something to be said about the width of the QRS, but there's also something to be said about the abnormality of the electrical activation pattern. Not all patients, as we spoke earlier with respect to Eric's presentation, that not all patients respond as well to resynchronization therapy. And a part of that is, even if the myopathic process is similar, the electrical activation sequence can be very variable from patient to patient. And I'm putting 3 simplistic activation sequence that we all understand and know and exist. That's left bundle and right bundle with left anterior hemiblock. And all of you who are familiar with CARTO maps know that the early activation is here and the delayed activation out here. In the right bundle, the early activation is here on the right side, delayed activation on the right side and early activation on the left side. Having said that, there are right bundle branch block patients who have a wide right bundle that there can be masking of a delayed activation on the left side. And we know that from endocardial activation sequences. And that, I think, again, is important to understand when we start thinking about resynchronization therapy in patients with right bundle. So when we say that patients are non-responder or there's variability in electrical activation sequence, I think we need to understand that the one-size-fits-all strategy that we have for putting a lead in the lateral wall of the left ventricle doesn't always work. And it doesn't always work, not for our lack of understanding about the activation sequence, but of our lack of understanding of where we need to appropriately target those patients to reset the electrical activation sequence. Now, for all the EPs, I think we all recognize that there are so many factors that can impact lead location and response to LV pacing, right? This could be the presence, what the substrate is. This could reflect the underlying scar that the patient may have. We know that more scar is associated with worse outcomes. It can even reflect the surrounding tissue health. So where your lead is located, how the health of the tissue around that is, so it can take in the electrical impulse and activate the rest of the heart is also important. And then the extent of the RV-LV fusion, the areas of slow conduction, the proximity of the pacing electrode to the Purkinje network if you're going endocardial, and then also beyond that, what is the electromechanical coupling? What is the orientation of the electrode? What is the myofibrillar pattern? So it is a complex issue. And oftentimes when we have non-responsiveness in our patients, there are a multitude of factors that we are not accounting for or are at this point in time not able to appropriately phenotype that could be impacting the outcome of a patient who gets an LV lead. So I think it's really important to kind of put this in perspective before we classify a patient as a responder or a non-responder, and happy to answer questions related to that. But sticking with the theme of implantation, because I know this is an EP summit and that's what interests people. Folks don't want to hear about optimization, and I totally get that, and about follow-up. Patient selection is really important, but after you select the right patient, I think it is so important that we put the lead in the right place. And we have shown through the MADED CRT study that if you put the lead in an apical location, you land up translating into worse outcomes. So any apical location versus a non-apical location, as you can see out here, these patients actually do a lot worse. And I think it's pretty simplistic. If you have an apical RV lead and you have an apical LV lead, you're really pacing two anatomically closed regions. They're not electrically distant, they're not anatomically distant, and the potential for having relentless RV pacing translates into these patients actually developing more heart failure. So I think that's a lesson we learned, but not all apical lead locations are also equal. And I'm not going to get into that, but there is evidence that we've shown from our center and other centers that if you can get an apical lead in the position that exists, that's the only game in town. If you have electrical delay in the area where the apical lead location is, you're still pacing an area that's electrically delayed in its activation, and the potential for response in that particular spot actually translates into reasonable outcomes. And I say this based on our work and other work from Michael Gold that has suggested that we did some CS mapping with the EnSite system. We found the area that was most delayed and the area that had scar, and put the lead in an area that was most electrically delayed by a measure that I think everybody now recognizes as the QLV, or what we call in our center as the LEVLED, that is left ventricular lead electrical delay, which is a percentage of the QRS width. Again, happy to answer questions related to that. The bottom line is that if you get a lead in an area that's electrically delayed, the potential for response is much higher. And this was a secondary analysis in about 500 patients that were blinded in the SMART-AV study. And we were able to show by getting a lead in the electrical delayed location, it translated into an improvement in end systolic volume and diastolic volume, as well as ejection fraction and quality of life. So basically making the argument that individualized lead implantation strategies are important, trying to get a lead in an area that's non-apical, preferentially in an area that's electrically delayed, translates into these patients doing well. Now, that works well when you look at large randomized trials and you put all these patients, wide QRS patients together. It looks good and it works well. And we said, let's take this to the next level. Let's see if we can individually target the left ventricular lead in non-left bundle branch block patients, a mix of IVCDs and right bundle, and try to get into an area that's electrically delayed. And does this translate into patients doing better? And the answer is, at least in this study, which was just in about 185 or almost 200 patients, which is randomized over 40 centers, where we did a traditional arm of LV lead pacing versus the LV electrical delay arm, and found that actually there was really no difference in clinical outcome between the two arms. But the interesting part of the study was that the overall response in purely a non-left bundle branch block patient was about 72%. So these patients actually did really well with CRT, as opposed to the previous literature data, which I think many years ago we were doing, implantations in really narrow non-left bundles too. And I'll come to that. I'll come to that in the end of this conversation. But the important thing out here is that there was a significant overlap between the traditional arm and the LV lead implantation arm by the electrical delay. And really, we were not able to tease out any significant difference between the two strategies, but clearly indicating that non-left bundles still do well with resynchronization therapy. I'm going to shift gears out here. So resynchronization therapy in its conventional form works well, but the new kid on the block, and this is work that Rod Tung and Gaurav Upadhyay and Pugal Vijayaraman and others have done, and I will quote, done phenomenal work in the arena of conduction system pacing. And Rod's here with us today, so I'm hoping that he can answer most of the questions on this too. But having said that, I think we recognize that, that we talked about his bundle pacing, we talked about left bundle area pacing. There's an uncertainty about where we get into the left bundle when we do a left bundle pacing. And that's why it's called left bundle area pacing, because you may be in the common left bundle, you could be in the left fascicle, left posterior fascicle, you could be in the septal fascicle, or you could be in the anterior fascicle, although the anterior fascicle is oftentimes very rare. And that's why it's called left bundle area pacing. His bundle pacing, although, is physiological, is upstream, is elegant, I think we all recognize has its own issues. It works really well in the most experienced hands. However, in ordinary hands like mine, the propensity for having high thresholds and dislodgements or later on following them up and the thresholds really being much higher have kind of veered us away a little bit from his bundle pacing and more into the left bundle area end of things. And we'll talk about that a little bit. Now, I know most of the folks on this call probably already know a lot about left bundle area pacing. None of the pictures I show out here are labeled for the use, but they're being used by us in our center. For one, as opposed to a lot of other folks who go in with preformed shaped sheets, I usually go in with a deflectable C304. It's easier, get me quickly to the spot I want, adjust for the size of the heart also. And I put in a 3830, and I'm not going to go into the details of it, screw it in, do a septogram, make sure that it's adequately deep inside the interventricular septum. You can see out here that there's a gradual transition from the W pattern in V1 to a terminal R in V1, and indicating that you now have left-sided conduction system capture with delayed activation on the right side, indicating that you're getting appropriate left conduction system capture. Now, many nuances about it in terms of ventricular septal pacing versus left conduction capture, and we can talk about that later on. But the bottom line is that it's a terrific strategy. It provides us the opportunity of actually implanting conduction system pacing in the left bundle branch block patients that actually has a failed LV lead implantation. So patients who are conventional candidates for CRT fail an LV lead implantation, we are using this as a bailout. And we use it with the 3830, as I showed you, but you can also use it with direct stylet-driven leads out here, as can be seen out here. And they work well. And you can see in this particular patient who failed, and this is courtesy Gaurav Upadhyay, You can see a patient that had a failed LV lead implantation. He used a stylet-driven lead out here and was able to narrow the QRS from 180 to 122 milliseconds. So we see this often enough, but having said that, it has its own challenges. And if you look at the most recent data from the MELOS study, that actually specifically looks at a registry of over 2,500 patients across 14 different European centers, which was a prospective multi-center registry-based observational study, found that you can do left bundle pacing in patients with heart failure quite well. However, the presence of heart failure itself was a determinant of failed left bundle area pacing. Many reasons for that, because the interventricular diameter is much bigger, the reach is poorer, the conduction system is splayed in such a way that you're not always into the conduction system. It's a guessing game sometimes as to where you are. And there's also evidence that the more progressive the myopathic process, the wider the QRS, the lower the possibility of getting a successful area also, because that may indicate distal conduction tissue disease, and you may get into the left conduction system, but you may not have adequate narrowing of the QRS. And I'll show you a lovely example in 2 seconds from now. And the problem is also that there are associated lead complications. Obviously, we have lead complications with LV leads that we're all well aware of and have been doing it for the last 20 years. I think it's important to recognize that left bundle branch area pacing has complications in almost 8% of patients. These can be acute perforation to the LV, could be lead dislodgements, can be fractures or a damaged helix, or a delayed perforation, because you may not know exactly where you are, and then over time, you may be just at the conduction system, it can find its way into the LV, and that has been seen in some cases at our center and at other centers too. This is a really elegant case. We've all done left bundle area pacing in CRTs, and I've even done them in non-responders, but this is an elegant case from Pugel that was recently published. He actually goes systematically in a patient who was getting CRT to see how we can use other forms of therapy to ensure that we're actually getting good resynchronization. So if you bear with me out here, this is an 81-year-old with an EF of 20%, NYHA class 3 with a left bundle branch block of 210 milliseconds, right? And you can see that this is left bundle branch block out here. Pugel initially did his bundle pacing in this particular patient and was able to elegantly get the QRS narrowed down to 150 milliseconds. Not terrific, but certainly much better than the 210 milliseconds. Unfortunately, the capture there, the threshold was really high. The threshold was as high as, I think, 5 or so, and they could not pursue his bundle pacing because of the threshold, and also there was some instability out there. So proceeded down towards left bundle area pacing. Left bundle area pacing was able to capture the conduction system, and there was an improvement in the QRS now, not as much with his bundle pacing, which preferentially probably got the infrahisian left bundle fibers, but was able to actually at least narrow it down to 180 milliseconds. Not very happy with that. He put in the left ventricular lead out there, and you can see the left ventricular lead in the posterolateral region out here, reasonable location, and found that the QRS now was 170 milliseconds with biventricular pacing, as you can see out here, was reduced. Now, they did not optimize the AV interval and tried different combinations, but nevertheless, the QRS was 170 milliseconds. What he did then, which we have done in pacemaker patients, was actually combine left bundle with left ventricular pacing, was able to narrow the QRS down to 144 milliseconds and really translate it into a much better outcome, at least by the electrophysiological changes in this particular patient. So what I do want to bring out here is that we have many things in our conduction system armamentarium now, whether it's his bundle, whether it's left bundle, whether it's a combination of his bundle and left ventricular lead, or whether it's a combination of left bundle area pacing and a left ventricular lead, which is LOTS CRT, which also can help these patients. Now, I say this because, we've done a lot of studies at our center and other centers trying multiple combinations of left ventricular leads. There is the multi-point pacing study, which was recently completed and was stopped because of futility. But when they did a sub-analysis, they did find that wide spacing of the multi-point pacing in patients who got greater than 98% pacing actually translated into non-responders becoming responders. So I wouldn't wipe off the multi-point pacing slate and say these patients don't respond. But I would say for certain that there is a subset of these patients that actually can respond to this therapy, and we should watch out for which patients already have CRT, is to try multi-point pacing in a more individualized approach.
Apologies for interrupting, Dr. Singh. Just a quick heads up that we're at about 4 minutes.
Excellent. I will finish in 4 minutes, I promise.
Thank you.
And then we have quadrangular pacing out here, which you have 4 leads, 2 in the RV, 2 in the LV, and you can create a greater capture of the myocardial tissue and actually translate and converting these into responders. And then you have triangular pacing, and happy to answer questions related to that. This is the new kid on the block. This is leadless LV pacing. This is a study we're doing called the YCRT study across Europe, Australia, and the US. We're almost close to completion of the study right now, looking at some interim analyses, and hopefully, if things work out well, could be a late breaker at HRS. Bottom line out here is that you have a battery pack that gives ultrasound waves, that paces an LV endocardial electrode, that then translates into resynchronizing the heart in these patients. And you saw that the cartoon with the delivery of the leadless endocardial lead. Now, YCRT can also allow us to deliver the LV endocardial lead directly in the left bundle area pacing. And as you can see on this EKG out here, RV pacing EKG and left bundle area pacing with the selective delivery of the leadless LV electrode can translate it to narrowing the QRS out here. And this, I think, is eventually the future paradigm as we move. If I'm going to ask for 30 seconds more, this is a really interesting case, which I think highlights that we do not understand everything about CRT. This is a 44-year-old lady with ovarian cancer who received Cytoxan, so the mated chick population with chemotherapy and cardiomyopathy, with a QRS width of 180 milliseconds. And IVCD came to me with class 3, class 4 NYHA, twisted my arm, asking for device therapy and asking for something that would improve her heart function. I asked this question to many EPs at many symposiums, what they would do, and they all said uniformly they would not do a CRT because the QRS is just 118 milliseconds. Maybe consider CCM or something else, but we're not inclined towards a CRT. This lady read our mated chick paper, insisted on CRT. We made a case after doing some mechanical desynchrony measures to put a CRT device in. And from 118 milliseconds, she became 82 milliseconds, and her ejection fraction improved from 20% to 42%. So I want to throw this out there that an IVCD with a QRS of less than 120 milliseconds with chemo-induced cardiomyopathy, we were able to change the relative QRS from 118 to 82 and improve our ejection fraction by 50%, 100%. And something I would love to discuss later on during our discussion. But I will close with this final slide saying that integrating multidisciplinary care is really important. Selecting the right patient is really important. We have to get better at phenotyping the myocardial electrical conduction tissue disease. And there are multiple different strategies now that we can use for pacing. They can be single site pacing, multi-point pacing, left bundle area pacing, his bundle pacing, multi-point pacing, and many other therapies. So thank you for your kind attention, and sorry to go over time.
Not at all, Jag. You certainly didn't go over time. I gave you a little more time, and you took it.
Thank you. Thank you.
So you're right in your space. That is an absolutely wonderful tour of CRT and where we're heading with CSP. I have so many questions, but we do have a break. So I think what I'll do is the chairman's prerogative. We'll take a break, and then we'll come back and we'll continue. We'll let Dr. Tung do his VT. I don't want to cut in too much to the unknowns and cases because everybody likes to go over them, but we could take a little time and maybe go back, maybe 10 minutes and do a little discussion. I just want to say one rejoinder to your wonderful last case. There is an old statement that one swallow does not a summer make. So I think we all have to be a little careful. We always seem to remember our successes. We tend to quickly forget our failures. So
for sure,
I just want to warn all these listeners, 200 of them, that I don't want them all going out tomorrow and thinking they're Jag Singh. So anyway, Ashita, we can take maybe 10 minutes, then we'll come back.
Perfect. 10 minutes is good. And we'll have some music on. So when you hear the music stop, you know it's time to get back. 10 minutes.
Thank you.
Thanks.
We back on?
Yes, we
Hello?
are. You're live.
We're live. Okay. A couple quick things. First of all, I'm going to bring Dr. Tung on and let him give his lecture to us on VT. But I just for the other faculty, Jag and Doug, please check the Q&A. There's some things specifically to your talks in there that we didn't get to. And you can, I've been doing this throughout the program. Maybe you can just get back to the question or just do a private back to them. You can answer, like type your question in there, just so we'll be able to get there. Jag, there's a couple for you in there. And then I'll handle later somebody, I haven't even shown my unknowns yet, but somebody's asking me about maneuvers, but we'll get to that later. Rod, you with us? There you are.
How is everybody doing?
Hey, Rod. Okay, so listen, let's try, because we're going to try to keep, we'll give you 25 minutes. You good with that? And then we'll move on to the second, the other parts of the program.
Sounds great.
All right, take over, Rod.
So it's a pleasure for me to talk about some of updates in VT ablation and some new insights. And I am equally conflicted with different industries. So the inherent limitations of ablating VT is that the vast majority is unstable. And the question is, do we really need to see the circuit to destroy the circuit? We would need better clues during sinus rhythm to be able to give us some sense of where the highest yield areas are. There's often multiple VTs. Endocardial is what's standard. How often is it mid or epi? And most of our construct of VT is actually based on models. And that's because El Sharif showed us that there's a figure of 8 on the surviving epicardium on a canine LAD ligation 3 to 5 days after during non-sustained VT. And that's actually our construct, is that sort of model. And then Bill Stevenson's model was actually based on computer simulations. And it wasn't until the 70s, late 70s, where just the finding of diastolic activity was really what made us, This was quite sobering in 2008 when I was completing my fellowship, that the best of the best here were succeeding about 53% of the time at 6 months in the Thermocol trial. And I remember really trying to push this forward and make VT ablation better. And this is just that famous Thermocol figure that shows that about half have very significant reductions in VT. The ablation strategies that are used for VT are typically trying to do what Giordano was doing, like an encircling ventriculotomy, or just drawing transections across like the Europeans like to do, a T-shaped lesion and smash, which is to try to hit the sides where it could be exiting out, and then go deeper into the scar to give yourself a chance to transect an isthmus, or homogenization, which is just blanketing the whole scar with red dots. And homogenization is probably the closest thing we have towards surgical resection, which was very effective if you didn't die. And here's just an example of what the famous Pennsylvania peel with Harkin, Horowitz, and Josephson is. But homogenization, which is really a European concept introduced by Andre Natali, Piaget, takes about 74 minutes of ablation, plus or minus 21. So sometimes you're burning for an hour and a half on its own. So that's very, very extensive. The more you treat, because if you had a pest problem in your house and the exterminator said, I will treat every square centimeter of your home. Well, the real question is that necessary? One of the most important things that when we talk about VT ablation, we put everything in one bucket. But non-ischemic cardiomyopathy now is almost more prevalent than ischemic cardiomyopathy with regards to referral patterns and what we take on. And there's been a lot of insights into our collective understanding of non-ischemic VT. Basal paravalvular scar, first shown by Henry Shaw, Frank Marchlinsky, and Dave Callens. And most of this happens with where the VT sites of origin are. And this is what we learned. This is what I learned as a fellow. This was published in 2003. And when you go to the epicardium for these patients, which Kyoko Sojima and Stevenson started doing, you can see that the epicardium typically has more scar than the endocardium, making us really understand that this is just not like ischemic cardiomyopathy. And when you look at different scar patterns, which we talked a little bit about with even ICD stratification, you have no business trying to burn on the endocardium for pattern D when it's epicardial. It's almost like trying to ablate a left atrial flutter from the right atrium. It's very unlikely to get transmurality and be able to eliminate that, which is exactly why Sosa and colleagues in 1996 said for pattern D, we might need to put a needle in there. And there's that very famous picture with everyone learning, Sonny Jackman, Doug Packer in that picture, watching the needle go in Brazil, and us borrowing those concepts and bringing it over to the States and globally. And here you can see in Oscar Cano and Frank Marchlinsky's paper in 2009, now 13 years ago, there are a lot more late potentials and abnormal electrograms on the outside of the heart than the inside of the heart in non-ischemic cardiomyopathy. Katja Zeppenfeld did a beautiful job to subtype this and said, anteroseptal subtype, infralateral subtype for non-ischemics. And the anteroseptals are really challenging because they often are intraseptal with that famous mid-myocardial stripe, looking like an Oreo cookie. And the infralaterals tend to be more epicardial, whereas an epicardial approach isn't going to help you too much when you're right on the left main coronary artery, the divisions of the proximal left coronary tree. So this is a really nice working construct. And a lot of the anteroseptal subtypes are now called peri-aortic VTs because they cluster within that first centimeter underneath the aortic valve. And when you look very closely at some of these VTs, which could have left bundle, right bundle, inferior axis, they tend to be very basal. Many of these VTs are actually micro-reentrant or locally reentrant. Here, density mapping of these VTs right underneath the aortic valve, and you can see on ice where these are located. And when you have high density electrodes, you can see on one bipole, you're recording all of diastole. That tells you the circuit's quite small if you can record all of diastole from one singular bipole. So this is quite beautiful because it actually lets us understand that, yes, these are reentrant, and yes, they cluster around the aortic valve. And here's just an example of one of those VTs that if you mapped it with lower density, you would probably think it might be focal if you didn't just get a little bit above it. It just looks like something's breaking out. But how beautiful is to show that these are some of the smallest figure eights in the world with these peri-aortic VTs. And when you talk about a grid catheter, it's actually just about the size of a US dime. And think about one bipole on that grid catheter. And that's how small human reentry can actually be. Well, non-ischemics do not behave just like ischemics. And at UCLA in 2010, Shiro Nakahara led us and showed that the scars are smaller in non-ischemic. They tend to be more epicardial. And the electrical signatures are different in the fact that they actually have fewer late potentials as well, more mixed tissue scar rather than these dense infarctive scars. And our success rates were quite different because non-ischemics were kind of a coin toss, but ischemics were about 80% success rate. And this has subsequently been shown by Frank Bogan's group and Borislav Dynov and Hendricks with a Leipzig HELP VT study, which shows that non-ischemics performs inferior to ischemic cardiomyopathy, probably fewer targets, probably less evident scars. And that's why non-ischemics remain an issue. Marmar Versegi led this study from the IVTCC, one of the largest retrospective databases ever done in scar-related VT, and showed that the type of non-ischemic you have can give you a prognosis. And the hypertrophs, the valvulars and the sarcoids are the ones you hope you're referring does not say that they have for you. You'd rather do the dilated cardiomyopathy, the ARVC, or the post-myocarditis patient. So The last thing to talk about with genetics and non-ischemic cardiomyopathy, as Jag alluded to lamins, well, if you have these genetic predispositions, they have very particular locations and they have quite dismal prognoses because these are progressive diseases. This was a great Brigham paper that came out with Lamin AC, and they really just concluded that so many of these patients, over 90%, experience VT recurrence, making us believe that this is actually probably palliative in genetic non-ischemic cardiomyopathy to get you to a heart replacement therapy. And here is just an example of a patient with VT non-ischemic cardiomyopathy, EF 25%. You do the MRI and you see this dreaded Oreo cookie, this mid-myocardial stripe that is right ventricular insertion in the LV all the way down to that inferior septum. And this is what you don't want to see. And this patient ended up testing positive for Titin. So those can be really challenges. And Lamin and Titin like to cluster around the periaortic regions in the septum. But for the infraletal subtypes and the ischemics that fail, it's this approach borrowed from Brazil in 1996, which is to do a pericardiocentesis with a dry puncture, get in either with an anterior or an inferior approach, and then be able to access the entire outer lining of the heart. There's about a 5% risk of bleed and a less than 1% risk of surgical conversion. And this is shared decision-making with patients. And one question that often comes up is, when do you go epicardial? Well, we talk about the fact that success rates are a little bit lower if you don't go epicardial, but then do you want maybe a 5% risk more of bleeding? Well, when you get to the epicardium, you can make beautiful, beautiful delineations of the VT circuits. And here in turbo speed is a grid that's sweeping across the epimyocardium, and look to see that you're actually recording all of this diastolic activity and prioritizing it with isochrones. And this is so beautiful to be able to see this sort of VT circuit. Here's a classical figure of 8 pattern. But what's really nice about this is that some really smart people in the past, including Jacques de Backer and Anton Becker, used to believe that it would be impossible for us to follow all the activations in the circuit. And what they believed that was impossible now, 30 years ago, is quite possible with new technologies. So we stand on the shoulders of giants with better tools and with higher spatial resolution with high density mapping. Now, the real question is, can we find where the problem's going to be, where the hurricane is going to evolve and develop during very calm situations? So this is the utility of a sinus rhythm surrogate. And fundamentally, you have to study this by being able to delineate the VT circuit, find where the isthmus is, and back solve it, and look to see what the sinus rhythm characteristics of this very special region is, what Mark Josephson called the path of righteousness. You can just eliminate this ball game is over. Well, we asked the fundamental mechanistic question, are late activated areas more important than slow activated areas? Because a late arrival is not the same as slow conduction. If you are late to the airport, it could be because you were late from work, you didn't pack your bags, your Uber was late, you got caught at security clearance, or you stopped to get a coffee. Regardless, you end up late at the gate. There's many reasons for the late arrival, and the mechanism is really something that might be proximal conduction slowing prior to that late arrival. So this would be what we call isochronal late activation mapping, and changing the SCAR map into something that looks just like a sinus rhythm propagation map. But we annotate everything to the offset of the electrogram to be able to include the late components. Whenever you see clustering of colors, isochronal crowding, it tells you there's slow conduction, because for the same amount of time, isochrone, you have less distance that's traversed. Therefore, colors are thin and wide colors are fast. So when you take a look at this area with crowding, it actually shows you there's a zone of deceleration in this region, and then there's late arrival after. So again, it's really understanding the genesis of late potentials, how they arrive, and where the problem actually is. Well, if you were to take a guess, if late is more important than slow, you'd probably say, well, in this context, I bet you he's going to tell me that slow is more important. And that is absolutely true. About 90% of the critical sites responsible for isthmus activation is actually in the areas that are just kind of moving towards the late zone. And the late zone is only 10% of the evidence that the latest late potentials may not be functionally most relevant. So we started targeting the areas of conduction slowing, the slow pathway for VT, if you will, and did a targeted approach instead of trying to burn the whole scar. And this would be an example of a patient with a circumflex infarction looking over the base to the mid. You change it to an isochronal map and look to see where there's slow conduction. Well, here there's slow conduction because there's a lot of colors crowding. Light blue's even missing here. And there's a little slow conduction there. Note that the late activation is actually all the way up the base of the ventricle. So this is what those electrograms look like, where they suddenly go from normal and tall to suddenly wide. And that tells you that there's a sudden abrupt deceleration in that region. So if you were to focus your eyes on this deceleration zone, which is chosen by functional substrate mapping, the propagation, and we induce VT, well, isn't that special that the isthmus is actually co-localized to the zone of deceleration? So if you never would have induced this VT, you create an isochronal map and just burn where there's isochronal crowding, you would eliminate a VT that you didn't even have to induce. So this gave us some really good confidence that most of these critical sites actually co-localize to these deceleration zones, to these wavefront discontinuities. So that just tells you there's a pebble in a stream, and that pebble in a stream is a great nidus for reentry. Fine. Is that really that much of a surprise? Yes, for some people that believe that VT is all functionally determined. And here you can see the VT circuit is beautifully delineated by pan-diastolic activation with this V-shaped activation on the right with the electrograms. And would it surprise you that if we can actually induce VT and map it, it doesn't take a lot of RF. It's almost like a pathway. 1, 2, 3, 4, 5, gone. So many of these VTs are quickly eliminated when you target them because you have such accuracy with high resolution mapping. And as a matter of fact, about 3 out of 4 times, we can terminate VT within the first 2 applications. And then in 88% of cases, you can render the VTs non-inducible if you induce immediately after the application. So this really tells us that VT might be more localized if we can actually get on it and portray it with high resolution mapping. So as we move forward here, what about the fact that there's all these morphologies of VT and there's like 6 or 7 and we're on VT number 8? Well, many of the times these isthmuses are shared. And that's been talked about for many, many years, nothing new. Mark Josephson has shown that in 1970s, 80s, multiple groups have shown it. But here you can just see examples in which this is a patient with left bundle superior axis, and this one is an indeterminate bundle with inferior axis. And you would say, that's going to be a long day. These are disparate regions. Well, not if you just turn the circuit 90 degrees and one exits out probably more apical and rightward, and this one exits cross, and it's basal. And what about this anterior infarction? Well, you have one that's spinning counterclockwise, and you got the other one that's spinning clockwise. So the exit is up here, anterior and basal, and this one here is apical and lateral. So sometimes you see the polar opposite QRSs, and you shouldn't fear. As a matter of fact, when it's exactly the opposite, you should rejoice in the fact that that could be a shared isthmus. As a matter of fact, 70% of the time when we had multiple VT morphologies mapped out, we could actually demonstrate a shared isthmus, which is lower than its true prevalence or incidence, because you don't always map every single VT with high resolution and high detail. So it might be more common than 7% of the time. When we did this isochronal strategy in 60 patients ischemic and 60 patients in non-ischemic, we got pretty good success rates compared to that 2008 Thermocool study, about 80% at a year. Now, that's not meant to brag. The point is that we've made some improvements. And as non-ischemics tend to still be inferior at 63. But what's more important, and I say this would be bragging rights, is that we only targeted 18% of the low voltage area by targeting where the crowding is. And that median duration of RF is just under a half an hour, rather than 74% with homogenization, leading us to the question, could this be as good as a blanket widespread approach because it's physiologically guided and more precise, teasing out where the more arrhythmogenic regions are within VT? Should you treat every area, and is every area of scar equally arrhythmogenic? Well, I would propose to you, no. There are some regions that are more prone to reentry than others. Now, the last concept is the fact that we always think about VT with the Stevenson model spinning on a singular tabletop or in a planar fashion. And when you think about VT, you think about two-dimensional reentry on the endo. What would happen if you look epi? Just a focal breakthrough. And here, the other way around on the bottom, an epicardial reentry is all spinning on one plane. What happens on the other side? Focal breakthrough. That is a very simplistic idea of VT. Is that really true? Well, here would be an example of an inferior ischemic cardiomyopathy patient that doesn't have a full circuit. It would confuse the mind because something looks like it breaks out, and then it actually looks like it almost dives into another little wormhole here, but you're not seeing continuous activation on the endocardium during an inferior infarct ischemia patient. Well, what if we were to bring in the epicardium here? Does that find the missing components of the circuit? Well, here's the epicardium ghosting in, and you can see that middle portion that bridges the entrance and the exit, which is the only thing you see on endo, is actually indeed on the epicardium. And we were taught that this only happens 5 or 10% of the time in ischemic cardiomyopathy. Well, when you have this again, does it take a lot for VT to go away? You put your catheter right in the middle of it on the epicardium and you come on ablation. It doesn't take a lot. So here you can see again, we're about to start RF. The ablation's there in the middle, and boom, 1, 2, 3, gone, like a pathway. So VT might not need all that if you find where the issue is and you're on the right layer of the myocardium. And when you take a look at how wide this is, it's quite special because it's only 1 centimeter wide, this isthmus. That's actually quite small. And it only took one lesion to make it go away. And this one was rendered non-inducible with a singular lesion. Took 2 seconds. And we found that more than half of circuits have a minimal isthmus dimension of less than 1.5 centimeters. And that's actually one RF lesion. So maybe we don't need that much if we just have better mapping tools to be able to understand where we're at. The mid-myocardials will still be a challenge, whether you're epi or endo, which is why Doug's been looking at heated saline and needles to be able to get into there. So we kind of moved from a 2D construct where sometimes you see only parts of the circuit and you're missing activation. And maybe the other one, you have it all, to be able to start imagining VT in a 3-dimensional wedge model and thinking that maybe that surface fibrosis on the endocardium serves as an isthmus boundary in cross section. When you look at it in cross section, it's a perfect lateral boundary. It just has to do with what plane you're looking in. And when we start looking for these electrograms and diastole, we like to use high density linear catheters or grid catheters to be able to find all the diastolic components. And here's just an example.
Real quick.
Yep.
Just a quick heads up. We're at about 4 minutes, please.
Beautiful.
Thanks.
So what you have here is that you've got the complete circuit delineated. And this is something that's quite common now when you start using these multi-electrode catheters. Well, here would be an example of 83 cases that we published to be able to show you how much TCL you have in each one. Well, there's a lot of holes. Every one is a patient, and every area that's not filled in is missing cycle length. This should really impress upon you that there's a lot of missing activation during human VT, and that probably a logical inference is that it's in the mid-myocardium. And this would be what a mid-myocardial circuit looks like, in which you don't see everything on the epi, you don't see everything on the endo, and it would be a very logical inference that because this is still perpetuating, that the missing activation is probably mid-myocardial. And again, we looked at 83 cases, and we found that only 17% of circuits are restricted to one plane in 2 dimensions. As a matter of fact, only 7% in ischemic cardiomyopathy were 2-dimensional. So the real question is, what is an epicardial VT? There's so many different definitions. Is it that you've got the whole cycle length on the epi? Is it that there's more epi than endo cycle length? Is it that you have the entire isthmus on the epi? Is it that you have any part on the epi? I'll call it an epiisthmus. Is it that the exit site is epi? Or is it that it terminates on the epi? And when we put this on Twitter, most people like a pragmatic definition. That's not a biological definition. And the whole question is, I don't think we know what the definitions are, but we apply different definitions. And here would just be something to make you think twice when someone asks you if it's an epi or NOVT. This here has complete reentry on the epi, and you've got a little bit of light blue and dark blue. But when you look at the time at QRS activation, the moment of QRS activation, you have activation on both surfaces. The whole idea here is that nobody ever says that exit regions can actually be on both surfaces. And as a matter of fact, 2 out of 3 cases exit on both surfaces. So the next time someone asks you, does this VT look epi or endo? Say both, because that's what's most likely biologically. So we've evolved this construct of VT from the Stevenson model, the seminal work, to actually what looks more like a hyperboloid structure. And that hyperboloid structure, depending on how you cut through it, as if it were like an iceberg, that's what you see on the surface of it. And sometimes you're only seeing a portion of it, like the exit region or the entrance only. And you have to start believing that this probably is something below when you have simultaneous epi and endo mapping. In the last 1 or 2 minutes, we're going to talk a little bit about the impact of ablation on human beings. Well, does it improve mortality? This was a 2,061 patient study where we looked at patients that did not have VT recurrence after ablation. And we found that their transplant-free survival was much higher than those that had recurrence. Well, there's a lot of confounding variables because maybe those that have a lower ejection fraction have a higher risk for recurrence and mortality. But this was seen across all levels of heart failure as well as all ranges of EF. So this was the IVTCC study that showed that it's associated with improved survival. We know that SMASH didn't show mortality benefit, but there was a pretty good trend. And the triple composite in VANISH actually had the triple composite positive, but none of the 3 independently were superior when you ablated versus escalated therapy. And we just most recently published the PAUSE study in Circulation, which was the first trial to enroll non-ischemic patients, which again, as we talked about, are much more common. This was 121 patients, including ARVC, non-ischemic, and the early ablation at the time of ICD implantation for people presenting really reduced the composite endpoint of VT recurrence, cardiovascular hospital mortality, all driven mostly by VT recurrence. And there's this recent meta-analysis that shows that a VT ablation still has not been shown to have mortality benefit. Partita was just done, and that's a clear outlier with only 47 patients prematurely terminating because of mortality. But when you look across the board, there isn't an impact on mortality. It does reduce VT, it does reduce shocks, and it does reduce cardiovascular hospitalizations. So in summary, ladies and gentlemen, I believe we've made a lot of progress since 2008. We have a better understanding of subtypes. We understand non-ischemic is a wastebasket term, but we can understand what its substrate is and what type of approaches we need for septal versus epicardial. We understand the circuit is a 3-dimensional monster. We have better surrogates during sinus rhythm, like these deceleration zones and wavefront discontinuities. And VT ablation clearly reduces recurrent VT shocks and hospitalization. Larger studies will be needed to assess mortality. It took 8,400 patients in Paradigm to be able to show benefit from sacubitril valsartan. You think we're going to do that with 120 patient studies? So I think we need much bigger studies, a lot more effort, but maybe we don't even need to show there's mortality benefit. We'll have to wait and see. Thank you very much.
Thank you so much, Rod. Tell you what we're going to do. We're going to move. We're not going to take any Q&A quite yet. We're kind of running a bit late, but I do want to get questions. So I'm going to move on to the next section, that the advanced intracardiac quiz. We're not going to be able to get through all of them for sure, but let's try to get through some. And I'm going to ask my Medtronic hosts if they don't mind if when we get toward the end, at 1 o'clock range. I think that there's been a lot of people hanging in there. maybe we can take an extra 10 minutes to take questions.
Sounds
Uh,
good.
Does that
Perfect.
sound all right?
Good idea, Dr. Poppy. Yep.
Yeah, I think that'll be fun because I have written questions. We've been trying to answer questions online with those who send them in, but a lot of thought-provoking things have come up. And Rod, of course, is always one to do that. So for the listeners, let's go into the quiz. Trying to hold on a second here. Rob, I hit the thing that's okay, finally. All right. Okay. I've got the quiz here. So I hope people who are listening in on this can see this in detail. This is a tracing that I'd like you to look at, and I'm pretty sure, Ashita, we sent these out to all the registrants, right?
Yes, they have the handouts and it's in the chat box.
Good.
So, yeah.
So you have had a chance to look at it. And what I'd like to do is give you about 30 seconds to answer one of these questions. So here's the tracing that I'd like you to look at. And then here is the question. What best describes the findings in this figure? A, concealed conduction into the AV node. B, concealed conduction into the AV node and accessory pathway, or just concealed conduction into an accessory pathway. Rob, can you put up the figure and a answer sheet? Can we go back to the figure so they can see it? Or do I need to do that? I don't know quite how to do that. So here you have it.
You got it?
Yeah, I think we're good. So why don't you all take a look at this and put in option A, B, or C? You probably forgot the question now, right? So hold on. I'm going to go forward. All right, here's the question. I need 3 screens. I only have 2. Go ahead and put in your answers. We'll give you 30 seconds. You got any traveling music there, Rob? Apparently. No music. So you're just on your own to figure this out. Rob, can you show me answers coming in? Okay. Most of you got it right. Well done. Most of you, well, I guess not most. If I'm doing a trial here, guys, 50%, I guess, is the neutral line. But anyway, 50% of you got it right. We don't have a lot of time to go over all these, but so maybe I can ask Doug to quickly take a look at this. I put these out here, Doug. Just briefly explain what happened.
Well, I think that the group is right in that everything happened. I think the best thing to do when you're looking at a figure like this is to look at the ECGs first. So we have a paced rhythm. And it looks like it's in pretty good shape. I don't have calipers, but you can see from the right ventricular lead down below, from the ECG morphologies above, you can see that you have more V's than you have A's. Now, Eric, usually if you have more V's than you have A's, then you kind of think that there may be retrograde block. And so that might be something that I would jump to quickly. This is one of those, though, where you have to kind of stop and think again. Because if you look at that first QRS complex, there might be a His in the front of the V portion of the complex in the His bundle electrogram. And then you see activation that goes up and spreads out. I would have expected the higher A to have been out further, so I think you're probably going through the AV node. If you go out a little bit further, you've stretched it. you've got the same pacing rate, but you really stretch it. And you stretch it in two directions, Eric. You stretch it from V to A, but you also stretch it from A to your next V. And so I think you've got some, concealment into the V or into the AV node. But look at that little notch. If you can point that out, just right in front of that particular electrogram.
Can you see the arrow? I'm putting it on there.
I don't see it, but
Oh, really?
I can see my arrow. So.
Oh,
But the
no,
point is,
that-
you've got a little notch there, Eric, and for everybody who's looking at it. So I think you've got some prolongation of activation time from A to V, but you start out, go to the one before it. You start out before that, and there's a little right bundle glitch. And that makes me think that you have a fascicular-ventricular connection there. Now, as we go further along, that may be all that you have, but then the fourth electrogram is kind of looking a little bit more like the second, except for look at the long delay that you have going from V to A. And when you have a long conduction going to V to A, and if you have something on that first one that looks like there might be a pathway there, and you've blown both of them out, then I'm thinking that you've got concealed conduction into a couple of different pathways. Certainly the AV node, but I also think that you've got it in a pathway that's there. You go out a little bit further, and you see that now that last QRS complex looks different than the third QRS complex. It's more delta wave-ish. And if it's more delta wave-ish, Eric, I don't think that's going to be the fascicular-ventricular. So I think this tells us that we've probably got a pathway in there. And you can see that the V to H is very much foreshortened. So you've got A to an H, but you've also got a V there in a hurry. And so I think that you're getting a delta in there, which tells you that further on, why didn't you see it?
So,
And
Doug, we got to go a little quicker. I hear what you're saying, but I want to try to get through a few more of these.
Okay, but you've got two pathways, and you've got a fascicular-ventricular there, and then you have block as you've conducted into where the next V pacing would be. So
Totally.
that's my story, and I'm sticking with it.
Well, you're very correct, as usual. I'm having a terrible time trying to get this. Can you see this laser pointer coming on and off? For some daggone reason, Rob, it's wish I could just take the daggone thing off. But anyway,
I see. Do you want me to take it, remove it?
yeah, please. It's just driving me crazy.
Okay, just give me a second here.
Eric, something you can do is up at the top where it says View Options.
Yeah.
Click on that, and you can go to annotate. That's not going to give you a dot, but it can give you a circle that you can mark.
Yeah, I thought I could. You can't see my just my arrow here, guys.
Intermittently, we see a red
No,
buzz.
can you see the white arrow I'm moving along now on the slide? No,
Mm.
no. Okay. Well, sorry about that. It's on my screen, but Rob, if you have some clever way, I can point things out. But the bottom line is, Dr. Packer is right. Whether you want to think that's a hiss or not, it doesn't matter that much. It makes the story better, but he's correct. You have an A and no hiss here. You have an A and a long hiss here. So obviously there's concealed conduction into the AV node. You have a delta wave out here, correctly as Doug said, and you don't have that delta wave here. So you conduct into the accessory pathway, and he's right to also bring out the fact you have a curio here, and it turns out that is consistent with a fasciculo-ventricular connection here, pathway, that is just an oddball there. It doesn't do anything, so I didn't put that into it. But so you have an interesting group of physiology. Well done, Doug, as usual. Let's go on to the next question. I only have a couple I'm going to try to stop us at around 12:30 or so. So I'm going to try to make these as quick as we can. This is this happened to a patient who's had multiple episodes of palpitation. She's in a treadmill. 4 minutes into recovery, she's in tachycardia, and naturally occurring PVC terminates it, and then she goes along and starts herself again. So, having said that, I'm going to ask you, what's the mechanism that's most likely? Is it most likely AV node reentry, AV reentry, or an atrial tachycardia? And you all should have the actual tracings because we sent them out. Let's see. Somebody asked me, can we agree that more than one accessory pathway, very unlikely? No, because there was 2 pathways. And then he said, never mind, I got it. So good. Getting it's good. All right. Enter your answers as soon as you can, and we'll let somebody else go through this. But the problem is you could spend 20 minutes discussing each of these, and you're not going to be allowed to, faculty. I want to get through some of these so we can go on to some cases. What have you got here? So 56% think it's AV reentry. It's a very good group out there. That is correct. And Rod, you want to take it quickly? You guys, or I can do it, whichever you all would like. Why don't I do this one just to only because of time concerns, and you guys can jump in because
I think Rod can do it.
well, I didn't say he couldn't do it. All right, Rod, can you do it in a minute?
Sure.
Go ahead. I'll start.
I might not do it right, but I can do it in a minute. So what you have
Well,
there,
I'd rather give you 2 minutes and get it right. No, I'm teasing. Go ahead.
I'm actually, can you go back to the tracing itself?
This is
So
it.
obviously,
Yeah.
anytime you have a PVC that affects the tachycardia, atrial tachycardia is less likely, although PVC that gets to the EA can still affect AT. So that's why I would probably put AT at the bottom of the list. The interesting thing here is that looking at lead 2, that rhythm strip, the P wave is deeply negative, and it looks like a long RP tachycardia to me. So if anything, that's kind of an accessory pathway if it's AVRT with slow conduction properties retrograde. Now, I was going to say that that's so long, that's also strange because I don't know if that's a conductible PR for AVRT. If it's so long, it's not conductible. It could be done in series rather than in sequence, and that would go for atypical AV and RT. But I think what you're trying to get at here is that if a PVC can terminate tachycardia, it's usually AVRT or AVNRT. And I think it's still debatable. I mean, it's still possible that it could be an atypical AVNRT.
Okay, well, that's a very good description of the tracing. I think you're absolutely right. AT would be lowest on the list. It doesn't rule it out, but it would be, if you just look at the timing, right, Rod, where AA and then where the next A would be, the next A, the V would have never gotten back to the A, right? I just think timing wise. So I think you're 100% right there. And then comes the question of, was this PVC likely to have occurred when the His bundle was refractory? And I think that's where you use your imaginations. You put your calipers here and you say, okay, here's the P wave, somewhere in here is the His, maybe 40, 50 milliseconds in front. And then you move that over to here and you move it over here and you find out you're doggone close to where a His would be. So just to show you in the lab what happens, here's that long RP tachycardia. It was actually coming up a bit on the left side. It wasn't really far left. It was just a little bit on the left side. And a PVC in the lab inserted exactly when the His was going to occur, terminates tachycardia without going back to the atrium. So that point, it's game, set, match, and you got your diagnosis. So it's really a question of looking at the tracing carefully, and you can't see it on the screen. I had the advantage of having it in front of me with calipers, and you just guess the His is going to be about right here. And where's that next V? And could that have entered the AV node? And if you think it did, then you really don't know, right? Because actually a tachycardia of this long in RP is not infrequent with AV node reentry coming up in the posterior area of the septum. But in this case, the PVC occurs on the His. And of course, you can do other maneuvers. some people have been asking in the chat box about different maneuvers, but this is putting in, we like to put in for long RPs, PVCs in the His area versus, PVCs, because they actually more easily can get into the accessory pathway and bring it in. And it's not going to be an AV node reentry at that point. So anyway, I agree, Rod, in this case, it turned out to be an accessory pathway, easily ablatable, and patient cured. But I think your analysis of the ECG was important and spot on. So
Quick question, Eric. On that last one, you have a PVC that pre-excites the A and brings it in. Had you gone in the other direction with any of these VPCs introduced, such that you actually had the VA get longer at a time when a PVC is put at a time when a PVC is on top of a His?
yeah,
A Coltorti phenomena.
yeah, I know. I don't believe we did. I don't remember. I'm showing the one to mimic the ECG. This is the one that terminated it. We could pre-excite it, Doug. I don't think we ever post-excited it. So no, I don't think so. But I can't remember exactly in this patient. I mean, I was showing also this technique. A lot of people don't know about this technique, but we find benzopatinoum, publishes for us. We find it very useful in these long RPs because, as you well know, Doug, sometimes the PVC just won't get in there if it's very slow conduction. And if you put something in around where the His is, you're more likely to get into these long RPs. And it's a good differentiator for AV node reentry with a long RP versus AV reentry with a long RP. You're right. I know what you're getting at, and I don't remember that we were able to do that, Doug. I don't think so. I'm not positive, but
that's more for the audience, and it's also more for Rod in the issue of differentiating between an atypical AV node reentry retrograde and PGRT type delay.
Right. And I'll just tell you something. If you had given me this patient without that PVC terminating it, just historically, this was an older woman. I mean, I would have guessed AV node reentry. I mean, you don't typically see this kind of rhythm start, in somebody, and she wasn't old, by the way, but I mean, it wasn't somebody in their 20s or 30s. I think it was in her 50s. And, usually AV reentry rears its head like these kind of tachycardias way, way, way earlier, right, Doug, in life. So if you look just at the tachycardia without the termination, I would have probably guessed AV node reentry statistically, Rod, just like you were going for. But the PVC is the thing. That's why I showed you that strip, helps you differentiate those two. Somebody asked me, if we say that the PVC occurs when His is refractory, this supposes that there is a P wave that conducts to the His before the PVC. That is correct. That is right. Absolutely right. And if you look here, if we go back to the one where the PVC, hold on here, was refractory. I don't know why that did that. Sorry. Yes. So this P wave conducts here, and then this one is going up, right? And you can't see the P wave here, but you can see it here going up. So that would have gone down, right? So that's the point. You didn't see the P wave in that tracing either, because the PVC occurred, and it's a very good point you're raising. Oh gosh, it's very finicky. So you don't see a P here, but if you time it out, it's going to be in here. And Rod's point, which was an excellent one, you wouldn't expect this PVC occurring at this point to have affected the atrium. Just run the numbers. If a PVC occurs, it's got to go from the ventricle through the His, on up and hit to the atrium. And the P wave timed out should have been right about here. There's no way that PVC could have affected the atrium. That's what Rod's point was. It was spot on. And that's your first observation, rule out atrial tach. But the questioner is right. You have to suppose it would come down. And so, yes, there would have been a P wave here, but we terminated tachycardia. That's the point of the question. And if you So yeah, that's the point of the question. Doug, did you have something you wanted to add? Your hands up.
Well, go back to the ECG.
Okay.
This just to make a point on the AV node reentry versus the kind of a PJRT-like delay. So the first 3 beats you've got, they've got the late and inverted P waves in 2, 3, and AVF. You don't see AVF there. Then PVC terminates it. And then you've got a couple of sinus beats. You have 1, 2, 3, 4, 5 sinus beats. And if you're just looking at that, that would make you think what you've got is atrial tachycardia. But then automatically you've got the retrograde P wave on the 6th beat, or just before the 6th beat, that finally gets AVF in harmony with 2 and 3, where they're both negative. And you're doing that without much of an APC to incite that. This is the business where on PGRTs you can induce it without an APC.
Yeah. And the other thing, I didn't want to get too into the weeds, but the other thing that helps you is if you measure the RP here and the RP when you start, it's almost identical. There's really no reason you should be married to the previous R wave if it's an atrial attack. That's kind of what you're saying, Doug. It should come in any old place, right? So the fact that you have a married RP here to here is really classic for either AV node reentry or AV reentry, and it wouldn't be atrial attack. That's another. I was trying to teach the point of the PVC, but you're right. That's why I said some of these traces you could go on for 20 minutes. I'm going to try to get one more in. I know Dr. Singh had asked me earlier when I was talking to him, he goes, well, how many tracings do you have? I said, too many, Jack. So now you understand why. I knew we'd never get through them all, but I'd like to get through one more because and I'm going to have Doug discuss it, but I'm going to let you all take a look at it. It's a very important point in this slide. But Doug, you can't take 20 minutes on. You got to promise me I mean, I know you can wax eloquently on this next one. So let me show this to the audience. And this will be the last unknown we'll do. Everyone's got it. So let's put the choices up. And if we could please, Rob, and then give you a little time to answer. I'm sorry. I should have done one thing first. My apology here. Here's the question. Is this tachycardia AV node reentry with aberrancy? Is it an anadromic reentry? VT, or an atrial attack with bystander pre-excitation? And I can tell you the absolute answer is on the tracing. You should have the tracing, so I'll leave the question up so you can remember what your options are. And I'll give you about 30 seconds. And then Doug, can I give you no more than 3 minutes to discuss it?
I'll take 2.
I'll take that. That's fine. So go ahead, everyone. Try to put your answers in, please. So Doug, wow, good group, huh? 43% took option B. I'm going to let you discuss it. Your hand is still up. I don't know if you want your hand to stay up the whole rest of the time. You're driving me crazy with your little hand up there. Stop it. Okay. I knew it. Here's the problem. The audience doesn't know what he's doing. He's just flashing his little hand up because Doug Packer is being Doug Packer. Douglas, I have put all the numbers on for you. So why don't you wax eloquently?
Okay. First, I'm just going to make a comment about the surface complexes. You've got 1, 2, 3, V1 and V2. As you follow those along, then you've got pretty equal cycle lengths between them. And then after you get through that pacing spike, the next ones are earlier. The other ones are later. But see what's going on now is you've got in your His bundle direction, you can see a V, an H, and an a V, and an H, but you're putting in an APC at a time when your low septum is refractory. And so it's going to advance, the next complex. It actually occurs too late to be doing much with the surface QRS, but it's going to advance. But I think the important thing is you can see the V, that's 272 milliseconds. And so that's advanced compared to your 284. And then you go up and you get a His and you get an A. So your VHA. And it turns out that this is a long VH coupling interval, which brings in not only a tighter V that's early, and a tighter H that's early next, and then the A that's still early. You might lose a little bit as you go through that, but you got an APC introduced into a wide complex tachycardia at a time when the mid-septum low SA region is refractory, that advances the V, then advances the H, then advances the A. And about the only thing that can really do that, there probably is one exception that we won't talk about, is if you're looking at an anadromic reciprocating tachycardia, and you're doing this, and it's giving you information that's just exactly opposite of what happens when you put a PVC in ORT.
Great. So, as anticipated, Dr. Packer was 100% on. What he is saying is he's postulating this is the circuit. And the key, he had every key point. And the key points that I'm just going to say them again using the circuit, Douglas. So he's postulating you're going up the AV node, coming into the atrium. He's already mentioned that the QRS looks like it's coming from the left side. So you go down. And the maneuver is that we did is you put a PAC in, as he mentioned, somewhere close to where you think the pathway is. You wouldn't be putting it over here. And you want to time it, as Doug pointed out, so that you don't affect the A that's there, because you don't want to have any confusion that you got into the septal area. So these two cancel each other. This is the A that's coming up, and you don't change that. And you come down and you advance the V. Now, all you've said there, right, Doug, is you've proven antegrade conductions over a pathway. It's not VT, right? I mean, that's the point. But
to that point, that's all you've said.
Yeah. So, and that's something Doug had published on years ago in a lovely paper that you all should read on anadromic reciprocating tachycardia circulation. Douglas, I can't, in the 90s, right? Early 90s somewhere. Anyway, It's a paper you ought to all look at. It's a wonderful piece of physiology. And anyway, but then as he pointed out, you got to track it back. So now you've shown you're going over the pathway, but is that part of the tachycardia? Is it nothing else? So you track it back up, and it's exactly what Doug said. This thing comes back around, brings in the next A and His, and often you can't see the His. So Doug, here's what my thought is. Just take a second to see if you agree or disagree with me. I mean, I was trying to figure out why the His was so late, because His is usually not that late. And my postulate for this patient of mine was you were coming down the pathway, but you couldn't get back up the left bundle, and you had to go transeptal and come up, and that pushed the His to the end. What are your thoughts on that? That was just my postulate.
Well, as you go down through the pathway, then you're going to get a V. And then the issue is whether or not you go across the septum to come back up to A. So you're either going to have a long VH link there, or you're going to have a short VH link. If you went up the left bundle, it would have been a short VH link. But in that case that you showed us, it was a long VH link. It had about 60 milliseconds too much in going from the V to the His. And that's about what you get when you block in the left bundle like you've shown. You go across the septum, you're hitting up the right bundle. It gives you 60 extra milliseconds, and then you get a later His for a long VH, and then you get the A. And I think that the thing that's interesting is if you try to induce one of these, you almost have to always start with a long VH. in order to do it, then it may shorten up to a short VH. But I agree completely with the diagram. And I'm just throwing in why one pathway is a short VH and the other one is a long VH.
Thank you. Appreciate your discussion there. So that's what that one is. I tell you what, because I mean, people get mad when you don't explain other things. I'm going to really blitz. I'm not going to ask the questions. I'm just going to tell people, since you've gotten the unknowns, and then we're going to move to a case or two. We'll see how fast we go. And then, since Medtronic has graciously allowed us a few extra moments, I would allow some time for Q&A there with those excellent talks that the other faculty gave. This is the what's been called the Parahisian maneuver, and it's really only here to show you that not all, as Shakespeare said, not all that glitters is gold, right? So this is a wide QRS and a narrow QRS. In the narrow QRS, your V to A is shorter than the wide QRS, and the knee-jerk reaction is, aha, this is a AV node response. I don't like that because that's not always the AV node. There is an exception. This happens to be coming up, as I'll show you, a left-sided accessory pathway with a person who has a very poor AV node conduction. So what are we saying then? We're saying that if you look at a Parahisian maneuver, okay, and you have only an AV node present, yes, indeed, that when you paste the V, you have to go up to the A here. It takes longer than jump starting it up the His. I have no problem with that. And if you have a septal pathway present that conducts faster than the AV node, then it doesn't matter whether you capture the V and go up or the His or in capturing the His, the VA intervals will typically be the same. That's fine. But sometimes you have a left free wall pathway and very poor AV node conduction. So when you paste the V, it takes a long time to get up to that left-sided pathway, and it really never goes up through the AV node. And when you capture the His, you get on the superhighway, right? This is the stuff this is no different than Jag Singh was telling you earlier about how you affect conduction. These things all work no matter what you're doing, pacing for some patient or maneuvers. Once you get the His involved, it's not the RV pacing anymore, right, Jag? You've now got the His involved. So now you're on the superhighway and you get up. So in a situation like this, the VA is shorter when you have the His captured and longer when it's not. And it's not AV node. So just remember, there is an exception to that rule. In this case, in this tracing, I was going to ask you if it's Mobitz 2 or not. This part of the EKG is Mobitz 2, but there is a junctional premature. So you always have to consider there could be His extrasystoles causing this. And that may be the ECG is called Mobitz 2, but it's not really Mobitz 2. And here's the backup slide showing you a normal beat, a His extrasystole causes you not to touch here. So from a technical standpoint on the ECG, this is Mobitz 2, but we know the mechanism is really not Mobitz 2. In this case, it's due to concealed His extrasystoles. This has been called, as Doug Backer knows, pseudo Mobitz 2. I don't personally like that term because it's EKG wise Mobitz 2. It's just not mechanistically Mobitz 2 when you know the other bit of the tracing. And lastly, I think this is the last one. This is a patient who develops a tachycardia that's a left bundle branch block that narrows down. And it's just a question of measuring. If you measure the RR intervals here during wide and RR intervals here during narrows faster, telling you that unless you think this is a VT to SVT, but there's really no reason to think that, especially since a PAC in lead 3 clearly starts tachycardia, then this is clearly using the ventricle, and there's only one SVT that uses the ventricle, and that's WPW reentry. Here's an intracardiac showing you the left bundle and shortening, and that's all due to the fact the VA shortens, okay? So that was the correct answer there would have been AV reentry. Good. I know I went quickly. I'm sorry about that. If people have questions, I'll hang on at the end and you can ask me questions and I'll answer it in the chat room. Let's try maybe 1 or 2 cases if you guys are up for it. Let's see. Let me show you the first case. And I think they've been given the cases too, right? The audience, Ashita?
Yes, they have, Dr. P. The handouts have been given.
Okay. This is let's see if we can get, I'm gonna, let's see. I'm gonna do this one, and then I'm gonna go to a different case because I think it brings up a very important point. And I definitely want to get Jag involved there. This is a 34-year-old man's referred for recurrent syncope. First one was a year and a half ago while walking, and it lasted for seconds. The next one was 4 months ago at work. He was squatting, and then he suddenly had loss of consciousness for about 15 seconds. You know, I'm sure the faculty will confirm this. I never, if no one else is around to tell you how long they were out, I discount how long. I mean, people think they're out 10 minutes, you know? So, I mean, this is what he said. So I wrote it down. Several weeks of ECG monitoring done elsewhere disclosed a rare PVC. An echo was done that showed mild LVH, good EF, left atrium 3.5 centimeters, no family history of sudden death. Let me show you the EKG. Here's your EKG. Let's take a look at that. Okay. And then I went ahead and did an MRI, and the MRI shows that his EF is good. And as the faculty might have anticipated, he has apical hypertrophic cardiomyopathy, no delayed enhancement, and a measurement of 2.2 centimeters. And my question for the audience, and then I'll open this up to whatever faculty wants to discuss it. The question for the audience, what do you want to do next? This is your patient. You can either just follow the patient, you could do an EP study, you can put an ICD. I'm just curious what you want to do, and then maybe we can have either Jag or Rod jump in and tell me what you would do. So Rob, let's little music. Give him 30 seconds, and we'll get some answers. You can have answers even without the music, Rob. Okay, can we see the answers, Rob? So, Jag or Rod, since Doug and I have been monopolizing the time, either one of you want to take this?
Sure.
I don't care.
Happy.
So did you see the answers? Can you put them back up, Rob? I mean, they went kind of quickly. So the answers, Jag, are 52% said an EP study, 24% went with routine follow-up, and 24% want to put a defibrillator in.
Yeah, no, I think, so this is obviously, there's no clear answer out here. That's why you posed this question. I certainly would not go for routine follow-up unless I did routine follow-up with an implantable loop recorder to kind of have some documentation of what's transpiring. And if there's associated arrhythmia with the implantable loop recorder, that would be one strategy. An EP study in an HCM, is questionable to start with. You mentioned, in the setting of a preserved EF and HCM, I don't know what you're going to glean with an EP study besides probably looking at the HV interval and looking for other causes of syncope. VT inducibility out here is really, not as specific, or VF inducibility also is not as specific. So it's not something I would go down in a heartbeat, no pun intended. I would have some discussions with him because I do feel that, there's significant hypertrophy out here. That's one. Second is we know that apical HCM is associated with sudden death, and there are multiple variants for apical CHM, but a number of them are associated with sudden death. And I would have a discussion with, either going down the path of an implantable loop recorder and or an ICD, but I would be leaning towards an ICD myself. In this particular patient, but obviously I will go with a detailed discussion and make this a part of a shared decision approach with them.
So I'm going to tell you what I did and the reason for this. This is an area I've been interested in for many years. you get interested in things when you get sent patients, right? I started seeing patients. I have no idea why, is referrals to me with funny EKGs that look like this, and I started doing some research on it. I mean, not personal research, more like looking through the literature and trying to figure this out. Actually, I did nothing, but let me show you why. And I'm not going to tell you that that's true for all these patients, but um, I took an issue of doing nothing, and then I was not around. I had probably out giving a talk or something, but maybe I was more sensibly on vacation. But anyway, this patient came back with another syncopal episode. He was admitted to our hospital, and one of my younger colleagues immediately put in a defibrillator because now he's had a second syncopal event, and they all knew about the MRI. And what they didn't know was another piece of information of why I didn't do it. So anyway, 2 months later, he had another syncope and no arrhythmias. So let me tell you why I didn't do it, because I'm actually interested in this area. And like I said, I've had a bunch of patients like this sent to me. Let's take a moment to review this HCM thing, because you're right, it's a tricky area, and there's nothing more than type 2A information right out there. It's not like all the wonderful work you've done with ICDs and Doug with AFib. I mean, this is an area of judgment. So I'm not saying my judgment was right or wrong in every case, but I'll tell you why I did what I did. If we just take a moment to review HCM, it's been known for years that even one risk factor puts you at a higher risk for having a problem. And those risk factors typically have been, they've changed over the years. So let me kind of go that. I'll get back to the risk factors because they've kind of changed a little bit. But classically, we're family history of sudden death, a septum of 30 millimeters or more, or history of syncope within 6 months, right? That's the classic. Non-sustained VT in the early days, that's fallen out, and a drop in blood pressure on a treadmill, I mean, is fallen out. If you look at primary prevention ICDs, indeed, they're very, very useful. They're not, not as much as secondary, but that's true for all work we do, right, Jag? I mean, secondary prevention of VT is not the same as primary. So yeah, your inclination would be, as my junior partner, was we need to do something about this guy. He had recent syncope, and sometimes Prostowski's judgment isn't what Prostowski would like you think it is, and I'm sure he figured, what was Eric drinking that day? And he put in a defibrillator. So, and again, unexplained syncope, important 6 months though. I think this is a very important paper. If people haven't read it, I think you ought to go back and read it. It's a good message in this paper. All right. However, there's other information that's come along. As you haven't heard already, I'm a big fan of CMR in all these patients. And Doug, this comes back to an earlier point you raised. This is one of several articles that speak to this point. And the amount, and in fact, in an upcoming, I don't think it's ready yet, but I did one of my EP on EP things with actually Martin, who's worked on this area, and it'll be coming up. And he talked about this, and he said, yes, this is still what's going on. So here's a case where if you have minimal and regular HCM, okay, minimal fibrosis, you actually have low risk of dying suddenly, during follow-up. And of course, the more here's a case where you guys were talking earlier, indeed, more fibrosis, more risk, right? So this is one where the amount you have, but remember, this guy had none. And in addition to that, let's take a look at what he has. He has a variation of HCM that's been reported mostly in Asian populations. Here, I went back and reviewed all this literature, and there's different forms. This was a nice little schematic in one of the papers showing you that pure apical form, which he had, is apical hypertrophy below the paps. When it starts coming up the septum, you get mixed forms, and the risk stratification is different. So I called our MRI reader, and indeed he confirmed to me everything was below the papillary muscles. There was no aneurysms. There was no fibrosis, which changes the picture for sure. So if you look at those data, and you go back to an early study, this has been confirmed by others, more recent studies, patients who have pure apical form they do pretty well. I mean, they don't have a high risk of sudden death unless you put into them fibrosis, aneurysms, that changes the picture. And while the current recommendations for regular HCM would have definitely said that this patient could have fit into a 2A. Okay, I can understand why you want to put a defibrillator in that patient because he does have recent syncope. All right, he doesn't fit the other criteria, but he has recent syncope times 2. I thought it was vagal, but regardless, he did have recent syncope. And my point is that nowadays, the more recent guidelines that have come out in 2020, the HCM guidelines have at least put in some of these other things that include, for example, the CMR data. They can affect your decision. But again, this is all for HCM. And for apical, pure form, the risk of sudden death is exceedingly low. Again, nothing's ever zero, right? So when I spoke to this young man, I told him, I think you are at very low risk of sudden death, and I'm going to avoid a defibrillator. I wasn't there when he came back with syncope again, and my partners decided that no, we did need it. And then he has another episode, and there's no arrhythmia, which just proves for him his syncope was not VT related. And I am following a number of these people. I do not put in defibrillators in apical pure form unless something else is going on, like fibrosis or aneurysm. Either Doug or Jag, you want to?
Yeah, no, I think this is really elegant and, gives us an idea of how apical HCM should be risk stratified. Let me ask you, how about if you had seen him for the third time with a third syncope episode and he had not had a device implanted and you didn't know it was not arrhythmogenic? What would you do then? Would you put an ILR in him, or would you have then bitten the bullet and said, hey, this is the third syncope episode in an apical HCM, and even though the risk of sudden death is not as high as conventional HCMs, it's still there. How would you have approached him on the third visit?
Yeah, that's a great question. I think I love your ILR. I probably would have done that, but if I really, I'd hate for the ILR to show he died suddenly with VF, so I probably would have put a wearable defibrillator on him too, because he was having these fairly frequently. He was having them like every month, and even though I was pretty sure I was right, if he came back with a third one and I just wasn't sure, I would have either put either a defibrillator, but I don't know if I would have. But I like your ILR, but I'm not sure I wouldn't have also given him a wearable defibrillator, because it's not a good moment, right? If you find out, oh, I got the answer, he VF'd on my ILR, that's not a good moment for any of us. So I probably would have protected him if I thought it could be arrhythmic. But this is just out there, again, like you showed in some of your stuff. These are not easy choices, right? Especially recurrence of syncope. But I mean, if you really look at the data, it's in the favor of not putting it in. And we all know syncope can be, I mean, how many times have we all been fooled? I mean, I thought people had nothing. I mean, I've had patients where I've kind of blown off the syncope and then been embarrassed that they had intermittent heart block. I bet you I didn't, they had narrow QRS. I never figured for, I monitored them, and then oops, they have heart block. So, I mean, syncope is tough for all of us, and nobody's going to ever be perfect with it. But anyway, I wanted to bring the case up as an illustration of
a quick comment, if I may, Eric. His EKG showed that he had sinus tachycardia with a heart rate of 104, which was, I think, at least on the what you've written out there. Yeah, so I think that clearly points towards some sympathovagal imbalance.
That's a good point. Yeah.
Which, could be pointing towards the vasovagal nature of things out there too.
That's a good point. That's a good point.
That's interesting.
You picked up on that. I didn't. I probably just thought he was nervous. but you're absolutely right. And this goes to show you the art of electrocardiography, unfortunately, is not being taught the way it used to be. And there are tons of clues. I mean, you just mentioned one that I'm sure when I saw him in the office, I knew the pattern, and I probably didn't actually spend time thinking about the sinus tach. But you're right, that could show some autonomic, imbalance. That would have been another clue of what the mechanism was. That's an excellent pickup. Let me just get one more in here if I can, and then we'll take some questions, because there have been some from the audience, and then let everybody enjoy the rest of their weekend. I've been very impressed with, we have a lot of people. I'm going to skip this one only because I really want to get your thoughts on a very common problem that I have no idea what to do about, and I really want to get the input. So this is the third in your series of cases, everyone who's following along with me. This is an 86-year-old woman that I saw actually quite a number of years ago. She had a history of syncope before, but not after a pacemaker was implanted. So she did need a pacemaker for that, to take care of her Brady. She has a history of treated hypertension. She comes to the office for a routine pacemaker check. And anyway, she's got an echo just to show you the information she has. And this is what you find. Okay, so, this is a 6-month visit, and I sort of hate this observation. She's got this 2.4-hour long episode of clear-cut AFib. She didn't feel it, obviously, and no symptoms. And let's see what the audience will do. And then I'm going to throw it open to let the faculty tell me what you do with a patient. I think we all have to accept the fact no data are present of exactly what to do. I just kind of want to know what people are doing for a discussion. So you could either set her up for a routine 6-month office visit. You could start some aspirin, you could start warfarin, or you could start a DOAC. And why don't we give the audience a little time to answer? And then whoever wants to take it, just more from the view, we all know there's no data. So I'm just curious what people are doing these days. And okay, Rob, show us. All right, so a routine appointment, 22%, only 7% said starting aspirin, 2% love warfarin, and 69%, gentlemen, would start a DOAC. So if you add them together, you got basically 71% of people would anticoagulate this patient. Whoever would like to take it, just go ahead and start talking. I don't care. Rod, you've been silent. Dr. Tong, that's unusual for you.
Well, clearly we don't really know. It's about how much AFib there is and whether this is 6 minutes, 6 hours, etc. But I do think that most people err on the side of DOAC. I can't tell you how many people that are given CHAD 0, but often we get on DOAC. I mean, 1 is dealer's choice. But I err on the side of anticoagulation.
So let me ask you though, I'm not letting you get off that easy, Rod. So here's the thing. We all accept the fact there's no data. I know that, but we all see these patients all the time. So for the audience, I just want to we got 4 people who've been around for a few years. And I'll tell you what I do, but what is in a person with a fairly decent risk score? I mean, CHAD score. I mean, she had a score of 3 or 4. I mean, how much AFib pushes you? And again, I understand there's going to be pluses and minuses, but as a general rule, how much AFib do you need to see before you'll say in a high-risk patient, I'm going to start something?
I probably go with a 6-minute rule just because I believe most of this is epiphenomenon.
Okay, fair enough. Jack, how about you?
No, I agree with Rod, actually. I would have a low threshold, obviously making sure there are no other comorbidities and are recurrent or having falls with a risk-benefit ratio. But I would err towards a DOAC for a variety of reasons. But I do feel that, the AFib, again, is an epiphenomenon, which is reflecting other issues. And in an 85-year-old, I wouldn't be surprised if she has some atrial myopathy also associated over time that is contributing to the potential of her having a stroke from this. So, the burden, I go by the ASSERT study. The ASSERT study actually looked at this patient population with AFib duration. and as one of the sub studies, and they found that anything greater than 6 minutes was associated with stroke, but the longer the duration, the more linearity there was with the incidence of a stroke. So a burden of 2.5 hours, I would certainly go with the DOAC. If it was around 6 minutes, I'd be hemming and hawing, but still probably erring towards the DOAC.
Thanks, Jag. Douglas?
I think it's hard. Just because Taya said one thing in one paper and ASSERT said what it did, I don't think it gives you, a real clear idea. This is one area where I think you have a face-to-face conversation with a patient, and you talk about what the potential risk is of doing it and what the potential risk is of not doing it. I'm not going to disagree with the 6 minutes because of her CHA2DS2-VASc score, but usually I'm more of a 12-hour kind of guy.
Yeah. Well, I mean, obviously, I don't know either. And I think you said it very nicely, which is I'm sure every one of us does. And that is you have a sit down with them. The question is, for me, when do you bring them in? Because often these are just, they're sent in to you and, people have to travel. They have to come in. You could do a virtual, I guess, but it's really kind of better done. I think you would all agree if you're face to face, and because there's a lot of questions the patient's going to ask. And the higher the CHA2DS2-VASc, the lower my minutes are. I think is one thing I would say. But I've been looking at this just collecting for myself durations, and I can tell you that if I've been using more, and again, this is just me, like around 20 minutes. I've just seen a lot of people with like 5 minutes, 6 minutes, and you say 6 minutes versus 5. I mean, we all agree they're arbitrary, and I don't have an answer. But if there's a good CHA2DS2-VASc score, I mean 3 or more, something like that, and they're pushing 20 minutes or more, I begin the discussion. But I don't have any idea either. But I'm glad just to hear the array. I mean, I think this person I will tell you, I anticoagulated her. She was years ago and she got warfarin, but I mean, today I'd give her a DOAC if she would take it. And I'm not going to get into Watchman. I don't even want to go there with a left atrial appendage. I shouldn't have used the trade name, the occluders. But Doug, I do want to take a jump from this. Like I said, we're going to go into a little, just for maybe 10 minutes of Q&A, and then we'll end. Here's one of my concerns. I'm going to go back to your AFib stuff, that you were showing with the issue with remodeling and stuff. I'm not comfortable with the concept, even though I will admit I've occasionally done it, of kind of pill in the pocket anticoagulation for people who aren't like high risk. All right. There are people we all see, they may say their CHA2DS2-VASc is like 2 or something like that, and they're a man who have 2 or 3 episodes a year. They wear, some kind of mobile watch or, Fitbit or something. Because the concept there suggests, does it not, Doug, that the only time you should worry about thrombogenesis is because you're actually in AFib. And I'm just not comfortable with that. And I'd love to know your thoughts on it. When you brought up all that fibrosis stuff, even if you're not in AFib, you still have fibrosis. What are your thoughts on the concept of intermittent anticoagulation in AFib?
Yeah, so we have not yet included fibrosis in CHA2DS2-VASc scoring. But there are a couple of things, and one of the things we're doing out of Cabana is we're doing called a PALP score that allows for fibrosis and other components to get in there, and you get more aggressive. Ask Rod Passman. I think that we'll see what it looks like.
I'm part of that study, but I must say I was a little nervous signing up for it, because I guess what I'm saying is that if you have enough AFib, you were showing like all the burden and stuff. If you have enough AFib, you clearly showed, even though we haven't measured it, that you're going to get fibrosis, right? And if you have fibrosis, even without AFib, does that mean you're more prone at some point to a thrombus forming? I guess that's the question I'm asking you.
Yeah, we don't know that yet. You know, again, we know that, you know, if you're a HEPF or something like that, then you can get fibrosis, and with any other